and well-defined. I can't see any associated biliary gas with this calcification.
Okay, so the liver and the bowel were fine. Okay, carry on.
Yeah. So in this location, other differentials can include a dermoid.
So I'll stop you there for a second, just so I'm not worried about this calcified focus that you're describing. What do you think that is?
It may represent a dermoid, slightly large for a phlebolymph. Other vascular calcifications, I don't think it's within the bowel.
Okay, so let's not dwell on this too much. I mean, this is a calcified mesenteric node, if I was to tell you that. So we'll move on from that. Let's concentrate on the pelvic region. What can you see here? So
I can see a subtle area of gas around the bladder, or the bladder outline appears to be, I can see some calcification perhaps within the bladder wall.
Okay, so describe that. What can you see?
So slightly anterior or slightly superior to the superior pubic rami, I can see a well-defined wall to the bladder, which is slightly dense. It doesn't go through the whole bladder, but it's mainly in the inferior aspect. I think this is likely to represent, I can't see it throughout the bladder, so I don't think it's actually gas. It may represent calcification within the bladder itself. And given this appearance, differentials are quite broad. This may represent schistosomosis of the bladder, TCC, it may be other causes. Given this appearance, I'd compare it to any previous imaging, and then a CT for further.
Okay, so well done. Also, so just as a recap, as what you've said, the descriptive side of things is crucial for all parts of the fellowship examination. So you have correctly described an area of curvilinear calcification, which is just seen above the level of the iliopectineal line within the pelvic region, which broadly defines the outline of the bladder, and it is not associated with any other significant visceral calcification elsewhere. There is this incidental calcified mesenteric node, and as you quite rightly say, the most diagnosis in this case is schistosomiasis. Okay. Now, we're going to go on to another case. So tell me what you see here. No history.
So these are selected unenhanced axial CT images through the pelvis. The right kidney appears hydronephrotic with surrounding free fluids. Going further down, I can see a calcified focus in where I would expect the right ureter to be, and I can see significant calcification, which is again curvilinear and outlines the bladder wall. Having a look at the left kidney, I think I can see some cysts, but I can't actually see the left kidney very well. Given this appearance, it looks like there's calcification in the bladder, which is long-standing, with a right-sided hydronephrosis. With the free fluid, I'll be concerned about a calyceal rupture with a urine leak. And with this appearance, I would recommend a post-contrast CT to confirm this and referral to the interventional radiology unit for possible nephrostomy.
Okay. And your diagnosis ultimately is what? Sorry.
So the calcification in the bladder, I think it's most likely to represent schistosomosis again, or it may also represent TB given the calcification within the ureters, with an acutely obstructed right kidney, which may have ruptured.
Okay, good. Right, so as you described, there is pelvic calyceal dilatation of the right kidney, which is moderate to significant. There is part clubbing of the calyces, which is important. The important negative pertinent point, if you'd like, is that there is no cortical thinning. In other words, there is preservation of the renal cortex. There is significant perinephric stranding. There is fluid seen tracking into the perirenal space, thickening of the fascia of Zuckerkandl. There is a burnt out left-sided kidney, as you can see, with no renal cortex there. And within the pelvis, there is circumferential calcification of the distal ureter with luminal and wall calcification noted. Further south, you've got significant chronic bladder wall changes with thickening, with calcification of the bladder, which again is circumferential, and the features are entirely in keeping with schistosomiasis, as you say. This is the same patient with the coronal formats, and you can see exactly what we've described, with a lobulated outline to the left kidney, dilated and obviously not contribute function. The right kidney, and it's the important thing to note, is that despite the pelvic heliceal dilatation, which is the terminology I would use, has preservation of the renal cortical parenchyma. And this is the calcification as you've described. Referring to Chapman and our differential bladder wall calcification, bladder calcification, could it be either in the wall or the lumen? And this is obviously referring to the wall. Okay. Next case. So this is a diabetic, presenting with AKI and sepsis.
Okay, frontal radiograph of the abdomen. The right kidney is surrounded with free gas, which extends into the retroperitoneum. This will be in keeping with emphysematous nephritis. Emphysematous pyelonephritis. I can't see the outline of the left kidney, and I can't see any gas around the bladder. This is a surgical emergency. I would inform the urologist immediately about this finding and recommend urgent urology review.
Okay, so you've described gas around the right kidney. Is there anything else that you would like to describe within the right kidney or around the right kidney?
Yeah, so there's emphysematous pyelitis, and I can see gas in the calyceal system as well as within the pelvis, so it's quite extensive. I can't see any gas within the right ureter, so I think it's probably emphysematous pyelitis with emphysematous pyelonephritis and retroperitoneal free gas on the right-hand side.
Okay, so when you talk about the retroperitoneal gas, where is that gas seen to be tracking? Can you see any tracking here, or are you happy with that it's confined to the perirenal space?
It appears to be tracking inferiorly, so towards the right lower quadrant, sort of, and in front of the pelvis. This may represent some overlying bowel loops, but I can see mottled gas at the level of L4 and L5, which is in continuation with the kidney as well.
Okay, is there anything else? Are you happy with that? Is that so? I'm the consultant at the end of a telephone. I'm waiting for your descriptive finding of this radiograph, and you've finished, have you?
Having a look at it on closer review, I think that I can also see gas outlining the left psoas muscle, and having a look at the pelvis around the bladder, there appears to be areas of lucency, which is very likely to represent gas. So I think there's extensive retroperitoneal gas within the abdomen.
So the gas that you've described in the left psoas is clearly there. But what do you make of this? Can you see this?
Yes, I can see this.
And what's that then?
Is that surrounding the fascia, gyrotous fascia around the kidney?
No. So that would be ventral to the kidney and be seen on FAS. What you've got here is you've got ear tracking down the retroperitoneal segment of the paracolic gutter the ascending colon. So, and this is important to note that the ascending and descending colon have a retroperitoneal component, and therefore gas can be tracking down into the paragolic gutter on either side. Additionally, as you quite rightly say, there is gas seen laterally within the pelvic sidewall, and contextualize this with the IUCD device in situ. Okay, so in this context, this was emphysematous pylitis, and this is in keeping with gas in the urinary system. Okay. The differential you can see here, and again I'm referring back to Chapman, and I won't dwell on this, but you can read through the differential list here, because gas can either be in the bladder lumen wall or within the collecting system generically. Now this is another example of emphysematous pylitis, another patient, and I'll just go through a quick descriptive overview. You can see significant perinephric ear seen within the retroperitoneum. You can see ear within the calyces as well as the proximal ureter. There are multiple renal calculi seen bilaterally. There are further areas of gas formation demonstrated within the anterior aspect of the left collecting system. And a lot of the ear that you would see, generally speaking, within the collecting system, remember, is going to be is going to rise anteriorly, and given the density of air, and therefore is more often seen ventrally within the collecting system here. A further area of gas is demonstrated here. You've got gas inside the bladder, and this is consistent with emphysematous pyelonephritis, which is widespread and affecting both systems. Right, next case is a 70-year-old male. Just tell me what you can see in terms of calcification, please.
So there's calcification of the seminal vesicles. Sorry, the vas deferens. So calcification of the vas deferens, I can't see, and there's some phlebolysis in the right hemipelvis. I can't see. The most likely cause for this would be diabetics.
Would be a patient. Okay. And how do you think they would present with vas deferens calcification?
How they present? I think they're usually asymptomatic.
Okay. So they can present with no symptoms at all, and this could be an incidental finding, but they can also present with hematospermia. And the reason why we've shown you this is because of the vas deferens calcification has come up in the fellowship examination, so it's worth knowing what it looks like. Right, next case, we've got a 45-year-old female who is immunocompromised and is complaining of dysuria.
Okay, so frontal radiograph of the abdomen in a 45-year-old immunocompromised lady. In the left hemipelvis, adjacent to the ileum, I can see a oval structure with gas surrounding the wall. I can see some small bowel loops which have a non-specific bowel gas pattern.
Where specifically are you looking at, sorry?
So I'm looking at in the left hemipelvis, there appears to be an area of lucency. Having a look in the actual hemipelvis itself, in the bladder, there appears to be gas surrounding the actual bladder wall itself, with a curvilinear area of gas with a significantly dilated bladder. I can also see some surgical clips in the left upper quadrants. The bowel gas pattern is non-specific. I can't see any free abdominal gas. This would be in keeping with emphysematous cystitis.
Okay. So, as you've said, there is a curvilinear area of gas demonstrated, which is outlining the bladder, as can be seen within the pelvis. The bladder is clearly distended, and the ear once you have seen it within the bladder, you should always look upstream to the collecting systems to ensure that there is no gas tracking up into the upper tracts, and in this case there isn't. So the features are completely in keeping with emphysematous cystitis. Generally speaking, gas in the bladder wall only has a single differential, and it's worth referring to Chapman to review this in further detail. Now, this is an IVU examination, and a lot of centres, in fact most centres in the UK, don't use IVUs at all now. But can you get an IVU in the exam? And the answer is yes, you can. So it's worth having a handle on what sort of IVU films there are and what you're trying to look for. So I'm going to give you this image, and this is a plain film on the left, and the one where it says IVU is a 10-minute excretory phase study, and you can vaguely see a bit of fullness of the collecting system on the left side, and you can see a nephrogram on this side as well. You can similarly see the appearances on the right side, and so there may be a little bit of fullness of the left kidney. Can't really see a renal calculus. Now, same patient, this was a CT of the non-contrast CT of the kidneys. So you can see the collecting system indeed is slightly dilated. There is a calculus seen here within the inferior calyx, and there's a further partially obstructive calculus in the proximal ureter. And the take-home message is that although plain films and IVUs do have a role, CT KUBs have largely superseded, and CT urograms have superseded IVUs because of their sensitivity to pick up things like stones. Now, this is another case, so please describe what you see.
So this is an intravenous urogram, which is 15-minute delayed. In my routine practice, I would first compare to the control radiograph.
Good. Control radiograph was normal. Okay.
So having a look at the ureters, I can see both ureters have been contrast opacified. They pass through the normal expected location for the ureters and not displaced, and I can see them filling the bladder. On the left-hand side, I can see a expanded ureter within the bladder in keeping with a urethrosil. It's not causing any significant obstruction or reflux. I would do a more delayed IVU to check if they have a duplex system on the left-hand side, because they can be associated with urethrosils. Okay, so you would do what? Sorry, I didn't catch that. More delayed. I can only see, I can't see a duplex system on the left, but I can see a urethrosil in the bladder on the left-hand side. Yes. Okay. So what's the descriptive term used for that? Do you know what it's called? They call it cobra heads. Yeah, exactly. So it's a cobra head sign. Urethrosil's, you're absolutely right. So urethrosil seen there as a filling defect within the bladder. Occurs in about 1 in 5,000 to 1 in 12,000 children, and usually seen largely in the Caucasian populations. And females are more commonly affected than males, as you probably are aware. There is, if you've got a urethrosil, then there is an affiliation or a connection with other congenital urinary tract abnormalities that you need to be aware of. And urethrosil's can either be intravesical or extravesical. Where do you think this one is? Intravesical. Intravesical, good. Okay. So, but if it was to be extravesical, where could it be? I mean, where is the common site of ectopic insertion, if you'd like? Ectopic insertion. So I know they can insert in the ureter. Sorry, in the uterus is one location. If it was, if the ectopic insertion was inside the bladder, where could it be? Would it be medial or lateral to the BUJ on this side? Lateral.
No, it's medial.
Okay.
So it's usually more towards the midline, and so it's just worth bearing that in mind. So if you see something like this and it's out of line with the normal line of projection of the ureter, you need to just think about an ectopic urethral. Now this is another patient. This is a sagittal and transverse cuts through the bladder with an ultrasound. You can see a filling defect just demonstrated here, and this nicely demonstrates the urethral, as you can see there. Right. Next case, what do you see?
So there's bilateral renal calcification in keeping with, it looks like it's medullary-based calcification, bilaterally more so on the left than on the right-hand side. And differentials for medullary calcification include medullary sponge kidney, renal tuberculosis, and hyperparathyroidism.
Good. So so diagnosis here then?
I think it's most likely to present medullary sponge kidney.
Okay, so we've got a classic example of a medullary sponge kidney, and as you say, this is medullary nephrocalcinosis. So this is a spot diagnosis, really, isn't it? Now, we've got another case here. This is a 30-year-old male with bilateral flank pain and hematuria. Do you see any nephrocalcinosis on this on these ultrasound series?
So in the lower images, I can see some hyperechoic foci within the cortices, more so on the lower left image. I can't see any convincing acoustic, posterior acoustic shadowing. And if I have a look on the right image, I think there are some areas of hyperechoic foci, but again, I can't see any posterior acoustic shadowing. I think this would either represent calcification or possibly fat, but I'm not sure which one.
Okay, so slightly more subtle, isn't it, the changes that, and where would you say the changes are?
In the cortex.
Okay, so you think it's in the cortex. Okay, let's just, what would you do now?
So given that I found this finding, I'll first check if they've had any previous imaging, and if not, then probably would recommend the CT for a more definite diagnosis. Okay,
so we have the CT. Is this MSK?
No, it's not MSK, no. It appears to be faint, subtle calcification within the cortical-medullary junction. So this is more in keeping with cortical calcification rather than medullary calcification.
And why do you say that?
It appears to be predominantly centered in the cortical-medullary junction area, and it doesn't appear to be very diffuse. Slightly faint in appearances as well. So I think it's less likely to present medullary calcification.
Okay. So if I was to point out the calcification here being just above the convexity of a, or the concavity, sorry, of a calyx, where would that be? Similar appearances here. What would that location be known as? Is this more medullary or cortical, therefore?
I think if it's outlining the calyx, it'll more likely be medullary.
Correct. So this is medullary nephrocalcinosis. Just as a reminder to me, cortical nephrocalcinosis more or less common than medullary?
Cortical is a lot less common.
Okay. So cortical has a shorter differential, doesn't it, in terms of what the differential diagnostic possibilities are? Do you know, can you name two of those differentials possibly now that you've mentioned cortical?
So you can get it with chronic glomerulonephritis and chronic infections, and okay. It can also be associated with conditions like outputs.
outport cell captonuria, oxalosis. Okay, so these are the genetic chemical-related disorders that can cause cortical nephrocalcinosis. Medullary obviously has a wide range of differentials. Now, this is the same patient, and the patient indeed did have medullary nephrocalcinosis, and it was thought to be secondary to hyperparathyroidism. And in this case, the parathyroid adenoma was actually sited inside the thyroid parenchyma. You can see the carotid artery there, just to familiarise yourself in terms of the anatomy. And this is the outline there. And this is the MIBI scan, in which also shows and confirmed the presence of the parathyroid adenoma. This is the differential for nephrocalcinosis, and it could be medullary or cortical. And in this case, hyperparathyroidism has come up in the exam setting and is the second most common cause of medullary nephrocalcinosis after medullary sponge kidney.
Excuse me, Imran. We go to candidate 2 now. Candidate 1, thank you very much. Imran, can you hear me?
Yes, I can, sir.
So, candidate 2, can you please raise your hand? Yeah, I can see you now.
Hello?
Yes, we can hear you. Thank you, candidate 1. Imran, over to you, please.
Thank you. Hello, candidate 2.
Hello.
Right, so what we're going to now talk about is we're just going to go through prostates and prostate imaging. So this is but before we do so, I'll show you this film as a Viva film. This is something that's come out of our archives from 1973 from Basildon itself. Can you describe what you see?
Yep, so this is an intravenous urogram for a 67-year-old male. I can see an abnormality in the centre around the midline, just inferior to the bladder, which is causing a rounded impression of a filling defect on the inferior surface of the bladder. The bladder itself also appears slightly trabeculated with a lobular outline, and the collecting systems do not appear obstructed. So the trabeculated outline and the filling defect would make me suspicious of an enlarged prostate, possibly causing secondary outlet obstruction with chronic changes seen in the bladder.
Okay, and just do you see anything in the bone?
In the bones, yes, on review of the pelvic bones, I can see multiple sclerotic foci in both iliac wings and also possibly in that left proximal femora.
Okay, so
that would make me suspicious of a prostatic malignancy with metastatic disease, possibly.
Okay, so good. I mean, this is just as a teaser, really. I mean, it's an old film. It used to be the way before, in the good old days, how prostate cancer was diagnosed. I mean, you can see multiple bony metastases, sclerotic in nature, some of which are more confluent. There was partial distension of the right collecting system. There's a filling defect outlining the bladder, and you can see a trabeculated pattern as you've described correctly, and the features are consistent with disseminated prostate cancer. Now, we're going to go through multiparametric MRI prostates. The prostate imaging nowadays is obviously centered largely on multiparametric MRI scans, and gives you a weighted scoring system of how likely or unlikely you are to have prostate cancer. And this usually relies on a combination of three things: T2 weighted imaging, DWI sequences and contrast enhancement, and the combination of which is then brought together, and the scoring system is then is introduced, and this is based on the system called the PIRAD scoring system, which we'll just briefly touch upon, and the current version that's being utilised is utilising contrast enhancement. I'm going to concentrate mainly on T2 weighted imaging, however, because contrast enhancement doesn't necessarily come up in the exam at the moment, but it's the T2 weighted imaging that we're interested in, and what tends to feature are tumours in the peripheral zone, whether there's capsular breach or not, seminal vesicle invasion, nodal involvement, and bony metastases. Now, the typical sequences that are utilised for multiparametric MRI imaging is we use a T2, you can see here, T1 large field of view for the abdomen. T2 sagittal sequences are important. We use a DWI sequence as well as the ADC mapping. We use a T1 large field of view for the pelvis as well as a small field of view. And the mainstay of the imaging is this: it's the T2 small field of view for the pelvis and the prostate, and we use coronal imaging as well, and this is largely used for nodal definition. The addition, if you'd like, is the dynamic contrast enhanced imaging, which essentially are multiple sequential measurements, and this is important, that are taken post-contrast at 10 seconds intervals, and that defines the dynamic contrast enhancement nature of the prostatic parenchyma, and anything that shows early enhancement is indicative of something inflammatory or malignant. Now, this is a case. It's a 64-year-old male with a raised PSA. What do you see, please?
So on the selected axial T2 weighted images, I can see in the right peripheral zone there is an ill-defined area of low signal posteriorly, which is extending beyond the capsule with ill definition laterally, and perhaps posteriorly as well, but I'm not entirely convinced that it's reaching posteriorly to the rectum. I would obviously scan up and down to assess this further, as well as reviewing the sagittal images. On the selected images, I cannot see any suspicious appearing lymph nodes, and would obviously assess the bones in the field of view on the T1 image. So in summary, I can see a suspicious area of altered signal in the right posterolateral peripheral zone. I'm not confidently able to say exactly where it is in the prostate gland, at which level I mean, and I would also confirm these findings on the DWI and ADC maps.
Okay, good. So in essence, we've got a T2 weighted axial small field of view image, and as you say, there is an area of nodular change seen in the right peripheral zone base. The nodularity and the low signal change that you can see is at the 7 o'clock position, so it's well worth getting a clock face if you'd like, similar to the perianal fistula imaging that we use using a clock phase. So use that. That's 7 o'clock. You've got linear pericapsular striations. Do you see that? Linear and perpendicular to the capsular margin, and therefore this is indicative of a probable. Now, obviously, this can't be said in isolation, but the features here are suspicious for a potential malignancy with a raised PSA, and therefore this would be a possible T3A process here. Now, in terms of cancer imaging for the prostate, this I think is a really important slide, and I think we need to get a grip of this. And for the exam, particularly at this level, T3 definition is very important, and you need to be able to define whether the disease has breached the capsule. But also the other feature that is important is the subdivisions of the T2. So if you've got T2A disease, that means that you've got involvement of one half of one lobe or less. T2B disease involves more than one half of one lobe, and T2C is both lobes, and it's a very important way of allowing the clinicians to know that you understand the disease extent volume-wise within the prostate lobes themselves. T3B is seminal vesicle involvement, and so the T3 division is only A and B, and T4, obviously, just like any other malignancy, involves adjacent viscera. So, question to you, is there a tumour? Is there any capsular breach? And these are two different cases, so you can refer to them as case 1 and case 2, please.
Okay, so in case 1, I am suspicious that there is a tumour with low T2 signal in the peripheral zone and ill definition laterally on the left. So yes to tumour and yes to capsular breach. In case 2, I don't think that there is tumour.
Okay.
Yeah.
Right. So, so again, remember what we've said, and what what I emphasise is descriptive abilities, and that's key. So, this is to all the candidates that are listening. I mean, I'm particularly keen for you to be able to describe something such that at the end of a telephone call, I know what you're talking about as your consultant. And so to this end, we'll describe what you've just said. So there is an area of wedge-shaped low signal change on the T2 weighted sequences between the 9 and 7 o'clock position on the right side, and between the 3 and 5 o'clock position on the left side. The capsule appears to be stretched, and there's a possible ill-defined linear focus here. But whether that's capsular breach or not would need further imaging. Case 2 shows capsular bulging, and that's a term that we're using here. That's a particular term for prostate imaging. Capsular bulging with mass effect. You can see an elliptical nodular focus here, but the capsular margins appear to be maintained. Okay, so I would say possible T3A, T2 on this side. Right. Another Viva case, 2 different cases. What's your finding, please?
Okay, so in case 1, there is an area of low signal occupying most of the right peripheral zone, which is asymmetrical when compared to the left, appears smaller. There is irregularity of the capsule on that side also, and possibly some linear low signal extensions laterally at the 7 to 8 o'clock position. In the right clinical context, I believe these findings would be suspicious for a T3A tumour. In the second case, in the left peripheral gland, there is low to intermediate T2 signal in the left peripheral gland, extending from probably the 3 to 6 o'clock position. This, I believe, is extending beyond the capsule, where it's very ill-defined, and the signal changes are extending into what I think might be the adjacent seminal vesicles, which are of a similar signal.
Okay.
So that would be, if those findings were correct, obviously I'd confirm by looking through the rest of the images, but if those findings were correct, I'd grade that as a T3B.
Okay. Right, so just to go through that case, on the right-hand side, you've got, so description, remember descriptive tendencies are important. You've got a serrated margin to the right peripheral zone base. So this is important, is the volume of the prostate. You can see it's, the volume of the peripheral zone on the left side means that we've got still into the base of the prostate. So in terms of zonal anatomy, we can the base of the prostate is at the top, so it's not the base referring to the bottom. The apex is referring to the bottom of the prostate, and here we've got a large amount of the prostate seen, and therefore this is at the top of the higher end of the prostate, and therefore this is still the base. So a serrated nodular margin, which is contiguous with a soft tissue, with a lesion, seen within the peripheral zone. But I can't see the linear pericapsular striations that we've described before for tumoral extension beyond the capsule. So possible, but a serrated nodular margin, which is close. Now, the other thing that you need to know, and this is a distinction between the two cases, and this is important, that you can see the normal capsular bulge of a normal peripheral zone here, correct? On the right side, however, the capsular margins have been retracted, so there's a retractile effect from this tumoral focus. The case 2, which is deliberately been shown, on the other hand, shows a bulging effect of the pathological side, and the normal side shows a normal capsular margin which is not retracted, but it's in its normal position. So it's worth knowing that tumours can also cause a retractile effect as well as causing nodular bulging. And this was indeed a T3A process, as you described, not T3B.
Okay.
Right. We're just going to be going through prostate anatomy now. So just for those of you who are not familiar with prostate MRI imaging, so we've got an axial T2 weighted sequence that we're just showing at the moment, and what we're doing is we're scrolling south, and you can see here just in the background on either side you've got the seminal vesicles coming in, you've got the rectum here and the mesorectal fascia. You've got a slightly trabeculated bladder in this case, and there's the prostate that you can see here with the peripheral zone just seen there. That's the capsular margin just well demarcated there. So the rectum and the prostate, the interface needs to be defined. So what's important in MRI prostate imaging, particularly when you've got evidence of possible tumoral spread, is to talk about the rectoprostatic angle, because that preservation is crucial in terms of the disease management of the patient. Obviously, what's important is the seminal vesicles as well. And what's also important is defining your nodal places of nodal involvement. So where could the lymph nodes be? Well, so I'm just going to go through this as a thumb sketch now. Lymph node involvement in prostate cancer imaging in terms of pertinent negatives to mention. So it could be periprostatic, it could be perivesical, it could be pelvic side wall, obturator within this region here, presacral, or along the iliac chain. So always look up the iliac chain as well. Okay. Now in this case, there are no lymph nodes. This is a normal MRI prostate. This is a sagittal sequence, and what's important to do is go back and forth, and you can see the prostate here. Now, in terms of the prostate volume measurement, so the way I define prostates in my imaging, I look at the prostate volume, and the way you do a measurement should be an AP, and so I'll just go back to the previous here. An AP measurement here, an transverse measurement here, so AP times transverse times a long axis, and this is the way I refer to it, a long axis along the sagittal plane, and the multiplication of these three orthogonal planes times 0.52 will give you a prostatic volume. Now, the importance of a sagittal sequence is seen very early on, because if you've got tumoral extension from the capsular margin, it's one of the ways that you can define whether the tumour is indeed infiltrating the seminal vesicles. In the midline, you have the point where the seminal vesicles meet in the midline, and that's called the genu, as you know, of the seminal vesicles, and that's often a place where tumoral involvement can occur, and that's a T3B process. The other thing that a sagittal sequencer will allow you to do is define your median lobe. Median lobe projection into the bladder, and also whether you have visceral invasion of the bladder neck. That's very crucial as well. So get into the mode of looking at the sagittal sequence for definition of whether there's visceral invasion of the bladder, whether there's seminal vesicle involvement, the definition of the seminal vesicles, and look for symmetry on either side. As the seminal vesicle comes down, it tapers down, and that tapering effect should be present. If that tapering effect is gone or blunted, then that implies that you may well have a malignant process that's infiltrating the base of the seminal vesicles on either side. Okay, look for symmetry. You can look at the vas deferens as well on either side, and also the other advantage of the sagittal sequence is the definition of the posterior prostatic wall with the anterior rectal margin, and therefore definition of the rectoprostatic angle that we've referred to. The sagittal sequences are also referred to for lymph node involvement, although in my personal practice I use sagittal or coronal sequences. So the coronal sequences I find are very good for an overview of where the lymphadenopathy is, and for me that seems to be something that's very important. Now, for those of you, if you do prostate imaging or have seen prostate imaging, you often see a central median lobe, which is a common finding that projects into the bladder lumen, and that is a common feature of BPH, as we all know. The rate of malignancy in a median lobe is incredibly low, so prostate cancers very rarely affect the median lobe. So you may well see features that appear to be pathological, i.e. restricted diffusion on the DWI, but this is a take-home message that median lobe tumours are incredibly rare. Okay. This is a T1 weighted sequence, and this is useful in terms of the mapping of the bony pelvis and to look for any evidence of signal change within the bone marrow, to look for prostate cancer metastases, so sclerotic metastases. Here we've got heterogeneity of the bone marrow, but no bony metastases are seen here. And the other thing that we look for on a T1 weighted sequence is whether we've got hemorrhagic change, particularly within the seminal vesicles, for instance, post-biopsy or related to hematospermia. This is a large field of view of the abdomen, and we often incorporate T2 weighted sequences as matter of routine in most prostate imaging. So if that is asked of you in the exam, is there any point in doing abdominal imaging? Yes, there is, and it's T2 and T1 large field of view. And what we're looking for is any evidence of, I don't like to say hydronephrosis, I like to say pelvic head-cell distension, because I think that's more specific a term. Hydronephrosis is, in my opinion, is an overly used term. There's here you can see atrophy of the left kidney, normal appearance of the right kidney. This is important. Excuse me. And the other thing that we look for is any evidence of retroperitoneal lymphadenopathy. Okay, and that's the reason for doing the abdominal imaging. Now we're going to talk more anatomy now. So I'm going to use the image that we've had in one of the first cases. This is calcification of the vas deferens. Now, how does that define us or help define anatomy? Well, in this case, this is the corresponding MRI scan, and you can see how the calcification of the vas deferens has helped define them very nicely. You can see the mesorectal fascia here. You can see the mesorectal fat planes very nicely, and you can see that in most men, the vas deferens comes in medially, and you can see that it joins the genu of the seminal vesicles on either side. So the seminal vesicles bulky, coming in, and they immediately join. So that's the, let's go back, that's the tip of the seminal vesicles, and these are the tips of the vas deferens, so they're joining. So if we come back out, the vas deferens here, they come here, lying on the mesorectal fascia, or the fascia of Denon-Villiers. It does a U-bend and then starts to move ventrally. And you can see the calcification has also helped in terms of defining the path of the vas deferens. They move medial to the iliac vessels, and then they move laterally. And that lateral movement is very important. And you start to now see the early formation of what is the spermatic cord. And that then goes through the inguinal canal, just here. And that vas deferens then continues into the inguinal canal, into the scrotum. Okay, so calcification sometimes can help in terms of anatomical definition, and so I hope that was a useful delineation of the vas deferens as a whole. Now I'm going to show you a pathological case now, and this is a patient with T3 cancer, N1, M1. So let's go through this. So axial T2 small field of view. Remember, the mainstay of our imaging. And you can see a large mass effect crossing from the peripheral zone base between the 3 and the 6 o'clock position, and it crosses the interface of the transitional zone prostatic peripheral zone interfaces, the PZ-TZ interface that is now being breached by this large mass effect. There is also some further nodularity seen across the midline. And look what we can see here. You can see pericapsular tumoral breach into the periprostatic fat planes, with further breach seen on the right side. Okay, so there's evidence of tumor spread, and this is very nicely seen on the T2 weighted sequences. The other thing that you can see here, I don't know whether you can see that, but the levator ani muscle on the right side is fine, but the left side there's an acute angulation. So instead of having that broad curvature, you've got this acute angulation that's been formed, and this is because of tumoral invasion of the periprostatic fat planes, which is causing mass effect locally. So we've got a tumour that's clearly spreading outside, and the question then is it invading the seminal vesicles, and what else is going on? Well, this is in the context of a trabeculated bladder, and that's not surprising given the prostate size. And also additional to that, you've got this perivesical tumoral nodule. Now, the difficulty here is this is not typical for a lymph node to be located, because the lymph node locations, as we said, was peripheral, side wall, obturator, presacral, and iliac. But if you do get something here, this could be either a tumour nodule itself or indeed a lymph node. So it's worth bearing that in mind. Now, the sagittal sequence, as we said before, is used to define seminal vesicle invasion. So you can see the tumour here, and you can see that the demarcation of the seminal vesicle is very well demarcated on this side, as well as this side here. It's well demarcated. So although potentially there is tumour abutting the seminal vesicle, it appears not to be necessarily invading it. And there's no invasion of the bladder neck, but the bladder is seen to be trabeculated. The other things that we can see on the sagittal are the lymph nodes, and then we start to see changes within the sacrum as well, and these are things that we can define further through a T1 sequence. Now, this is a coronal sequence that I use to further validate any axial imaging showing lymph nodes, and here you can see very nicely large conglomerate nodal changes bilaterally, okay, in the context of this tumour. So we've got a, contextualising this, we've got a T3 tumour which has breached the capsular margins, and we've got lymphadenopathy. So we've got T3A, N1. Now, let's have a look at the T1 weighted sequences, and immediately you can see a sclerotic focus just seen there in the inferior pubic ramus on either side, and just anteriorly there on the left. And the features are obviously of concern for sclerotic prostatic metastases. Now, same patient, and this shows the significance of T2 abdominal imaging. And as we come south, you can see bit of fullness of the kidneys on either side, and as you come south, left paraortic nodal changes, and there's multiple lymph nodes that are visualized, and therefore that indicates, well, for example, that the degree of spread of the disease is beyond the pelvis into the abdominal cavity. So that was a T3AN1M1 disease, and that's the TNM classification. This is another example of prostate cancer imaging, and in this context, we've got to, again, start off with our axial T2 small field of view, and you've got a large mass effect here. There's a tumour, low signal change, and look at the proximity of the rectum with the posterior aspect of the prostate. There is tumoral extension seen laterally, posterolaterally on the left side, and there appears to be thickening and nodularity crossing the anterior mesorectal fascia. Okay. Now, also the other thing here is that you can see this appearance here, where there's eccentric thickening, curvilinear on the left-hand side. So we need to see whether there's any visceral invasion of the bladder neck. Now let's have a look on the sagittal sequences of the same patient. And here you can see a trabeculated pattern to the bladder. You can see here that there is tumour extension into the seminal vesicles. If we just go back here, this is normal rectoprostatic fat plane, and this has been breached here, and there is tumoral extension into the anterior aspect of the rectal wall. The other thing that we can see here on the sagittal sequences at times is the lymph nodes. The lymph nodes here are seen here, for example, at the level of the iliac chain. And then these are the coronal sequences, which then further validates or disclaims or excludes lymphadenopathy. And you can see them quite nicely here. So remember, coronals are there to validate or exclude lymph nodes that you've seen on the axial imaging. So all in all, this is a T4 tumour, and the baseline imaging of the axial, as shown here, has demonstrated rectal wall and bladder invasion, and the rectal involvement is subtle, but you can see these stranding, these areas of changes just seen within the anterior rectal wall, and the features are therefore those of T4 involvement of the rectum as well as the bladder, as you can see just here. Right, so that's the prostate sequence is done. So we're going to now resume the rest of the viva cases. we've done, obviously, some of the prostate anatomy. We've gone through some of the pathology, and I've shown you some prostate, typical prostate cancer imaging sequences. One of the sequences that we do rely fairly heavily on as part of the multi-parametric MRI sequences is DWI. And this is a sequence that allows us to really weed out the tissue within the rest of the prostate parenchyma to work out whether you've got an inflammatory process or a malignant process going on. And diffusion restriction, and I'm not going to lecture about this too much because this is quite complex and above the scope of this lecture. But we look at what's called the ADC mapping, which is the counter opposite of the DWI sequences, and the DWI sequences are based on something called the B values. Now, we start at Basildon, we've got 5 B values, which are all mentioned at the bottom of the screen, and these are the B values that we go for from 0 through to 1400. What's important to note is that if you've got a low B value, you've essentially started at kind of 0, and then i.e. the rest of the prostatic tissue is there, and then you start to negate and filter out other parts of the prostatic parenchymal tissue changes, and then eventually with the higher B values you're left with something that's cytologically abnormal, and therefore potentially could be malignant, or it could be edematous change from inflammatory change like prostatitis example. The higher the B value, the problem with that is that you start to get image degradation, and there's a high signal to noise ratio that develops with the higher B values. So you can only go up to a certain B value before the image becomes completely degraded. So that's the important take-home message. Now, I use a combination of, as we all do, DWI, but the ADC mapping is what I tend to use derived from the DWI sequences as a baseline slide for my prostate imaging. This is an example of someone who has prostate cancer. The image on the right side shows a high B value DWI sequence. So this B value could be somewhere in the 1000 or 1400 region, where the high signal characteristics of normal prostatic tissue has been now masked out because you've now come up to a high B value. So what's left behind is high density tumoral tissue, which is shown up as this high signal change. Now the counter opposite to that is on the ADC mapping, and that's a low signal regional map that you can see within the left peripheral zone, and that is your cancer. Right, so is candidate number 2 there?
Yes.
Hi, welcome back. This is a Viva question now, so we've got a number of sequences here. Just for orientation purposes, you've got a T2, T1, you've got post-contrast enhanced sequence here, an ADC map here, and you've got a series of DWI sequences here. The patient, in terms of the history, has got dysuria, fever, and perineal pain. So please tell me what you think.
Okay, so on the selected MRI axial images, I can see an abnormality in the left anterior peripheral zone at the approximate position of 2 o'clock. This abnormality is of high signal on the T2 weighted images, and demonstrates peripheral enhancement on the post-contrast fat-saturated images. On the DWI sequences, there is persistent elevated DWI signal with mild corresponding low signal in the ADC map. Just quickly looking elsewhere for any other focal abnormalities, the remaining prostate gland on these images looks relatively unremarkable. Although actually on the post-contrast images there does appear to be some peripheral enhancement, perhaps of the capsule.
Okay, that was thought to be normal.
Okay, so I think in summary, these signal changes would be, and in a patient with this history of dysuria, fever and pain, would be consistent with possibly an inflammatory process.
Okay, so would you stop there, or would you go on from there? What would you say?
I would correlate with the PSA if that was available. I'd like to backtrack on that conclusion, just thinking that the persistent elevation of the DWI signal is probably a bit more suspicious than I had initially thought.
Right. So start to put it together. I mean, you've come up with an inflammatory diagnosis. We have just to recap, we've got not one, but two, so almost a bilobed area of high signal change, which is fairly well circumscribed on the T2 weighted sequences with a degree of possible bulging of the capsule. Do you see that?
Yeah.
The contrast-enhanced imaging, and this is a dynamic contrast-enhanced sequences, demonstrates peripheral rim enhancement and a central area of low signal change, which could represent necrotic tissue within the middle, correct?
Yes.
The sequential DWI sequences starts to negate the signal out of the prostate, and then you're eventually left with this high signal change in the left lateral 2 o'clock position of the peripheral zone base of the prostate, and there's equivocal change, I must say, on the ADC mapping. But the fact is that anything that's T2 high signal is unusual for tumoral involvement, correct?
Yeah. Yeah.
Because all the ones that we've seen thus far have been low signal and demonstrate mass effect. Now, there is a bit of mass effect here, and the features here, given this persistence of signal change on the DWI sequences, and the peripheral rim of enhancement is a focal prostatic abscess, or a focal area of prostatic inflammation. But in this case, it was a focal abscess. But well described, but I would just commit a little bit more and note there are two T2 weighted areas of nodularity. So anything high signal on T2 with restricted diffusion is likely to be inflammatory until proven otherwise.
Okay.
Now, whoops, sorry. So this is the list of lesions that you could come across, and this, again, I'm referring back to Chapman. They could be solid or they could be cystic, and what we've been referring to is obviously an abscess in this particular case. Right, so now, next fiver question. We've got a 77-year-old male, and the patient has fever, and I'd like you to go through this and see what you think, please.
Okay, so on these selected contrast-enhanced axial, sagittal and coronal images of the abdomen and pelvis for a 77-year-old male, I can see an abnormality in the second and third axial images in the urinary bladder, which is fairly well distended and appears circumferentially thick-walled, possibly with some degree of enhancement, and anteriorly there is a large locule of gas. There's no catheter that I can see within the bladder that would account for this, so I would be suspicious of a more worrying etiology elsewhere.
Okay, can I just stop you there? So,
yep.
You've described a large locule of air. Have you described whether it's within the lumen or the bladder wall? Have you described?
I haven't yet, but I think it's within the lumen itself, because I think that I'm fairly confident that I can see an air fluid level within the lumen of the bladder.
Agreed.
On the sagittal image, there is another smaller locule of gas just on top of the dome of the bladder, but I think that might be within a bowel loop.
Correct.
On the selected images of the kidneys, I can't see any pelvic-calyceal dilatation or any significant perinephric stranding.
Do you see anything? Let's just go back into the pelvis. What else do you see?
I think that there are some enlarged right pelvic sidewall lymph nodes.
Okay.
I think just posterior to that right.
So basically, what you've got is you've got a trabeculated, thick-walled bladder.
Yep.
Do you think that there is any evidence of any perivesical inflammatory ground glass stranding that you can see?
Yes.
Yes. So there's an element of that, correct?
Yeah.
So any ground glass changes that you can see potentially could relate to an inflammatory process. And then also, what's your opinion of the prostate?
So it appears quite heterogeneous.
Good. Okay.
Yeah.
What else do you see within the prostate in particular? Do you see anything at all?
Within the prostate itself, there's sort of punctate areas of low signal and peripheral enhancement.
Yeah, so there is heterogeneity of enhancement. Perhaps we can't draw too many conclusions. Sometimes we can with the CT. But on this occasion, there appears to be an involvement of the prostate, at the very least. There may well be a prostatic abscess here that you can see just at this point.
Yep.
You've got thickening and trabeculation of the bladder, and you've got perivesical stranding. So put that all together.
So these findings with the history of fever and dysuria would be in keeping with an inflammatory process, likely infective, possibly a prostatic abscess with secondary cystitis.
Okay, good.
The other way around.
Sorry. So this is an inflammatory process affecting the bladder. So you've got some sort of granulomatous cystitis with and obviously anything that becomes inflamed in terms of the visceral invasion of or involvement of the bladder can backtrack and involve the prostate, and therefore there's two visceral organ involvement, and that's the key here. So the pathology is one is intimately related to the other, and that's the take-home message. And this may well turn out to be, at the very least, a prostatitis, but at the worst, it could be a prostatic abscess related to an inflammatory process related to a trabeculated thick-walled bladder. Okay. Please remember to feed back on a regular basis. So that was there as a reminder to all of you. Now, we're going to go on to the next case. This is a 42-year-old male, and they presented with abdominal and flank pain, sudden onset of gross hematuria. Please talk me through what you can see.
Okay, so these are non-contrast, delayed contrast enhanced, and I think urographic phase images. On the non-contrast images, I can see foci of calcification in the left kidney, which I think are within the collecting system and possibly some are more cortically based. On the urographic phase, I'm not sure if this is because of the slice that we have, but there's no contrast within the left pelvic calyceal system.
Okay, so let's just because we're running short of time, just going to go through this. I mean, you've got plain CT, you've got some punctate areas of calcification that you can see here, and then suddenly on this you've got a nephrographic phase on the CT, and then you see this dilated segment here, right?
Yeah.
Okay, of this, and this is at the level of the medulla, correct? Now, this is further seen here. You've got what description would you say that? What does that look like here on the urographic phase? It's like a claw, correct?
Yes. So
there's a claw. Correct. There's a filling defect, and there's a claw appearance here. This is another appearance here. What's that appearance called? There's a filling defect in the middle of that. And you've got further filling defects. Sorry?
I can't remember the name of it, but I can see that there are filling defects with contrast more peripherally around it.
Exactly. So before we carry on, or before we go into into what this is, I'm just going to run through some anatomy with you. So this is a cross section of the kidney. Very crudely, you've got the cortex and you've got the corticomedullary junction here, correct? Okay, we talk about the corticomedullary interface, don't we?
Yeah.
Now, if you look here, you've got the medulla, which constitutes this triangular segment which feeds into the kidney and into the collecting system. And at the tip of the medulla you have the papilla. So that's the papilla, and this is the pyramid appearance, so-called, referred to because of the pyramid shape of the medulla. So the medulla are segments of functional anatomical sections, which is a functional driving machine of the kidney. Now the papilla floats into the renal, into the calyx, and so that's important. Okay, in between you have normal interspersed areas of renal cortical tissue, also known as the renal column of Bertin. That's interspersed, and sometimes they can be hypertrophied. Okay, so but at this on this talk we're talking about the renal medulla, and these are the phases of contrast CT, and we're just going to show you what I mean by that, the differential contrast enhancement in terms of nephrograms and so on. This is a non-contrast CT, it's a faint area of calcification. Here, this is a arterial phase, and the arterial phase is very good for definition of the renal cortex, okay? In contrast, the medullary pyramids appear to be low attenuation and have that sort of inverted triangular appearance. Do you see that? Okay, and that's typical. You have a division of major and minor calyces, and we can see major calyces are obviously larger than the minor, and then the renal papilla, as we just talked about here, are the apices of the pyramid which fold into the collecting system. Now this is a later image where the venous phase has started occurring, and you've lost that corticomedullary interface, and that's become one, hasn't it? And this is and from then you go on to the excretory phase where the renal papilla or the medulla have filtered their chemicals and the material and the urine into the collecting system, which is why you've got the urographic phase. And this is a three-dimensional volume rendered imaging. It shows multiple renal pyramids, which are centered around the collecting system. So there's an intimate relationship between the two. Now, as you can imagine, if one pathology affects the renal pyramids, it will then filter in and slough off into the collecting system. So this is another example of a anatomical outline of the collecting system, outlining the minor or major calyces, and shows the urographic or the excretory phase of a urogram. Now, what we were referring to in the images on the CT was renal papillary necrosis. So what do you understand from renal papillary necrosis?
So it's a result of ischemic necrosis, and you get faint sort of filling defect in the contrast enhanced phase.
Yes. Okay. So, and are you familiar with the signs? So the signs, and this is important because the renal papillary necrosis is referred to as sloughing of segments of the medullary pyramid, and this is a very good diagrammatic representation where some of this filters and sloughs off into the collecting system, and therefore the contrast on the residual aspect of the renal medullary pyramid is what's left behind, and that creates the lobster claw sign after the residual sloughing has already occurred into the collecting system. This is the ball on T sign, and this is literally just almost looks like a singular focus on top of a blunted calyx. Do you see that appearance there? You can see these appearances, and these are very classical, not quite pathognomonic, but fairly typical for renal papillary necrosis. And it's the sloughing effect that you get. Now remember, if you've got a back pressure into the collecting system, what happens to the calyces? They become clubbed. Now this is the end point where the calyces are where you've got severe hydronephrosis, but somewhere in between you get this effect here. So instead of the fornices, which are the outline of the concavity of the calyx, if that becomes blunted like it has here, that means that there is fullness of the collecting system from whatever outflow obstruction that you have, and that backfills and pressurizes the medullary pyramid, and you start getting an ischemic necrotic effect, which then sloughs off parts of the medullary pyramid into the collecting system, which gives you the signet sign, clubbed calyx, depending on the type of sloughing and where the pressure effect is felt in the renal medulla. Is that clear?
Yes. Okay.
So I know we're running short of time, but this is another an example of a back pressure effect. The calyces are clubbed instead of having their normal concavity, and you can see that's had an effect, pressurized effect on the medullary pyramid, which is sloughed off, and you start to see a separation of contrast from the collecting system as it starts to filter and slough off into the calyces and the infundibulae. And here, this is an example of the residual contrast that is seen once a sloughed segment of the renal medulla is left behind. This is an example of a completely clubbed and effaced medulla, because it's just this back pressure from the collecting system which has pushed this out. You've got very little contrast. You can only see the contrast on the sides. Can you see that?
Yeah.
So this is complete effacement, and where you've got partial effacement centrally, the contrast then fills in the rest of the space, and you get the signet ring appearance that you've got there. Now, this is a example of the same thing. We've been through this, but this is an overview again. So where you've got clubbed calyces, clawed sign, and the peripheral signet ring sign, and these are features of papillary necrosis. So whole list of causes, but generally speaking, there's a mnemonic, which is postcards, and I'm sure you know it, but pyelonephritis is important. And the take-home message here, that more than 50% of the cases of renal papillary necrosis are related to diabetes. And diabetes is fairly common, so it's not an uncommon finding, and it's a very common question, therefore, in the fellowship exam, and has been asked on a regular basis. Right, so we're now going to go on to our next slide. There is a differential in Chapman, and you can refer to our chapter which talks about causes of bilateral and unilateral renal papillary necrosis, and the type of necrosis, i.e. central forniceal fragmentation, is dependent upon the type of pressures that are placed on the collecting system itself, the concavity of the calyx. If the pressure is sustained, then this will push out and then cause a necrotic effect within the central medulla. And so this is what we've just described. Now we're going to move on to nephrographic patterns of enhancement. So where we've got a CT three-phase study. This is plain, arterial, and this is a venous phase study. And this is just a repetition, just so that we're all familiar with our nephrographic phases and patterns of enhancement. You can see that there's no distinction between the cortex and the medulla. Here there is a distinction between the cortex and medulla, and here you can start to see filling in of the medullary pyramids, which will eventually go to the excretory phase and start to pacify the collecting system, as you can see here. Now, this is something that is more and more used. Are you familiar with something called the in CT imaging, we use the split bolus phase? Do you know what that means?
Yeah, so you give one bolus of contrast, and then after a delay, give a second bolus of contrast, and what you should end up with is both an excretory phase as well as a sort of delayed portal venous phase imaging within the same study.
Exactly. And what's the advantage of a split bolus?
My understanding was that you get essentially both. You can garner information from both sets of phases, but within one image, rather than radiating the patient twice to get the same information.
Yeah, no, absolutely right. So so the advantage is that you expose the patient less. You get two phases in a single acquisition, and the way, as you say, for instance, if you were to do a CT plane and a CT urogram, here we've got a CT urographic phase. Just prior to the urogram being done, 70 seconds before, we give a bolus of contrast again. You can see the portal vein pacified, so you've got both the excretory phase as well as a venous phase of pacifying the kidney. So it's particularly useful for trauma and younger patients where the exposure is important. Now, please talk me through what you see here.
Okay, so on these selected IVU images, just working through them on the immediate film, I cannot see any definite contrast of pacification. On the 5-minute delay, there is some filling of the left pelvic calyceal system, but not of the right. And this is a persistent feature as we go through the 10 and 15-minute delayed images. There, on the 15-minute delayed image, there does appear to be some contrast within the urinary bladder, but still no contrast is seen within the right kidney or right ureter. So I would be suspicious of, in the right clinical history, an obstructed right kidney. I think that it is still there. I can make out a renal shadow on the first image. So yeah.
So the kidney, correct. The kidney is there. So your suspicion is of an obstructive uropathy, is it?
Yes.
So what would you do next then?
I would probably ultrasound the patient.
Okay, what else could you do?
I don't think there's any value in doing an extra delayed image.
Okay, no, I agree. So basically the take-home message is that the IVU, essentially, if you've done an IVU, you've got a whole series of sequences there. You know that there's a delayed unilateral nephrogram that you can see on the right side with no excretory phase demonstrated, and therefore, as featured here, the red arrow points out the obstructive uropathy as a cause for unilateral delayed nephrograms. There are patterns of nephrographic change that you need to be aware of. Where you've got an absent nephrogram, obviously you could have no kidney. There may be global segmental ischemic change to that kidney. But essentially there are 3 phases for everyone to be aware of. There's the corticomedullary phase, nephrographic phase, and then the excretory phase, which we all need to be familiar with. I won't dwell on this because this is can be referred to in Chapman, and I invite you to do that.
We have to now. Oh, sorry, I cut you there. You continue with your description, and then we will invite the next candidate.
Thank you, Dr. Khan. So I was just going to say the other nephrographic patterns, just very quickly. You can have a striated nephrogram. Remember the striated appearance of the renal medulla that we've described on the anatomy. You can get a similar effect in acute pyelonephritis as the infection backtracks into the renal medulla, and that gives you a striated appearance, which is very important to be aware of. And the other examples of striated nephrograms are due to sponge kidney, dystrophic calcification, and polycystic kidney disease. But I'm not going to dwell on this, and these are features that we can you can refer to in Chapman.
Okay. Candidate 3 is with us now, and thank you, candidate 2.
Thank you.
Thank you.
Hello. So, uncontrolled hypertension. These are 4 axial images of early phase contrast CT. I can see that the right kidney is hypo-enhancing in comparison to the left side. I can also see it's relatively smaller in size in comparison to the other side. Given the history of uncontrolled hypertension, I'm suspecting that there is a right renal artery stenosis, which I cannot appreciate on this.
Okay, so we've got uncontrolled hypertension. So essentially, we've got a normal contrast phase on the left side, and you've got the early corticomedullary phase. Here on the right side, you've got poor enhancement, so hyper-enhancing, as you say, but I wouldn't say that term. I would just say that there's a lack of enhancement, or a nephrogram which is slightly delayed. It's smooth outline to the kidney, and the kidney is smaller than that on the right side. So the features are therefore of something called renal artery stenosis. So there's reduced renal arterial inflow, and that's causing the nephrographic pattern that we've just seen. So these are the other patterns, again, that you can refer to in Chapman. Renal causes of hypertension. Renal artery stenosis is an important cause of renal hypertension, and again, that's important. Renal artery stenosis and the specifics, please refer to Chapman again. I'm an interventional radiologist, and we stent renal artery stenotic lesions from FMDs in young patients and atherosclerotic disease in older patients, and it's not an uncommon finding. So, very briefly, what do you see in this Fiverr film?
I can see a striated left nephrogram.
Okay.
Might be infarctions, might be pyelonephritis.
Okay, so why is it not pyelonephritis?
Because there is no enough fat stranding surrounding it.
Exactly. So the lack of fat stranding around the left kidney probably takes that out of the equation. Is this a typical pattern for pyelonephritis? No, it isn't. You don't tend to get this. What else can you see on the image here? Tell me about the renal artery and the aorta.
Yeah, I can see a calcific plaque, and the aorta is also atherosclerotic.
Okay.
It's not the ideal window, but I think there is a large calcific plaque at the origin of the left renal artery.
Okay, so I would, I'm not sure whether I can see what you mean, but there's certainly a significant area of renal artery stenosis demonstrated within the proximal left renal artery with pre-stenotic dilatation, and the features of those of renal artery stenosis and multi-segmental infarcts of the left kidney as a result of reduced inflow. Now, this is another picture. Just tell me what that shows.
So this is a coronal image of an CT or MR, CT angiogram.
So is this a CT angiogram in your opinion?
I can see what appears to be like aortic plaques, calcific plaques. I don't expect these to appear on an MRA.
Okay. So let me just stop here. This is an MR angiogram, this is a MIP, and this is showing a focal occlusion of the right renal artery, approximately 1.5 centimeters from the renal ostium. Okay, so it's a MIP and it's MR. This is another MIP, but this is from a CT. What do you see?
I see corkscrew spiral appearance of the right renal artery.
Okay.
Maybe small aneurysms or pseudoaneurysms from the middle segment of the right main renal artery.
No, I would disagree with that. I mean, yes, you've got a spiral corkscrew appearance to the mid portion of the right renal artery. So that appearance by itself would suggest a multi-segmental. So I'd be very careful about using terms like corkscrew. You can use them, but it's better to use a descriptive analogy before, just to say that this multi-segmental narrowing of the mid-right renal artery in a patient that otherwise has a smooth outline to the aorta and the iliacs. And that indicates to you that you've got a fairly normal vascular system elsewhere, but there's a focal area of disease, and that therefore denotes something like FMD rather than renal artery stenosis, which is seen in older population. What do you see here?
So this is a digital subtraction angiogram through the upper limb. I can see tight stenosis of both renal arteries, but more severe on the left side.
Okay, so how do you know it's tight? How can you use that terminology?
So I can see some collaterals around the stenotic segment on the left side. I cannot delineate the residual lumen itself.
Okay, so I'd be, again, refrain from using that terminology. So what tight you can't say, because what you can say is that there appears to be a high-grade stenosis in the proximal right renal artery, and there appears to be a rather fibrillated stenotic focus within the left renal artery. So the terminology here is crucial in terms of what the pathology is. And here indeed you've got bilateral changes within an aorta. The aorta as a whole on a background, so this is important, you say bilateral renal artery stenosis on a background of an ectatic aorta. Okay, so this could be FMD or this could be renal artery stenosis, but in this case this was bilateral renal artery stenosis in an older patient. Tell me what you see in this Viva image.
So I can see what appears to be a horseshoe kidney with a central non-enhancing isthmus. I wonder if this is a trauma patient or not.
No, so there's no history of trauma. There's just a history of intermittent visible hematuria.
All right. So there is the isthmus of the horseshoe kidney is non-enhancing. I cannot see evidence of stones, back pressure, or any masses.
Okay, I'll stop you there. So here, what you've got to look at is you've got continuity of a low attenuation lesion within the isthmus of the horseshoe kidney. It appears not to be involving the, so what's important again, description. So you've got something that appears to be cortically based, does not appear to be arising from the collecting system on either side, and appears to be causing local mass effect. Do you see that? So the presence of local mass effect within the isthmus of a horseshoe kidney, until proven otherwise, is a malignancy, and that's an RCC. Tell me about this case.
So I can see a hypoenhancing right.
So I'm going to stop you straight there. Your description also needs to account for the CT as well. So what you can say is there is a series of CT axial images of the upper abdomen, and then so very quickly you say it and then you jump straight in. Not I can see, because that doesn't give us the examiner an idea of what you can see. Please come on.
These are axial images of contrast enhanced CT of the upper abdomen and lower chest. there is a hypoenhancing right renal mass as eccentric in location. I can see it's invading the right renal vein and extending into the IVC up to the right atrium. I can see renal cysts on the contralateral side. So in conclusion, this is a renal cell carcinoma with extensive venous invasion.
Okay, so as you say, you've got a large renal mass arising from the posterior interpolar region of the right kidney. Remember, be descriptive, very important. It's causing blunting or local mass effect and splaying of the calyces, and there is extension into the right renal vein, IVC, and possibly retrograde involvement into the left renal vein, which is important. The IVC is distended. The IVC inside the sort of intrahepatic region is also dilated. There is free fluid seen anterior to the liver, and there is right atrial invasion. Right, solid renal masses we've just described, and we've just talked about renal cell tumours, and this is another differential list in Chapman that I refer you to. Now we're going to go on to long cases now.
So, Imran, you need help?
I'm just trying to, this isn't sharing.
Okay, so help is on the way.
Thank you. See the screen? Hello?
Yes, I can see.
Okay, lovely. So now I'm going to describe some long cases, thank you. So we're going to be talking about a tumour with enhancing tumour thrombus extending into the IVC. So this is an example of this, the sort of effects that a renal cell tumour can have, and this is what you should be looking out for. So look at the phase of contrast, and there's an arterial phase that you can see, and there's arterialization, if you'd like, of the IVC with heterogeneity of enhancement. There is local mass effect from the enlarged IVC, and this continues into the right kidney. So you can see this effect here. It almost looks like a secondary IVC, doesn't it? You've got the aorta IVC. So as you're moving from north, south, there's some low attenuation change at the interface of the left renal vein with the IVC. And then this dilated focal area of bulbous renal vein enhancement appears to be contiguous with an area of pathological change within the right kidney. Now, as we move on, we can see the same effect of the same patient on a coronal image, and you can hopefully see that there is extension of a filling defect and heterogeneity within the intrahepatic IVC. And remember that if you've got this change within the region above the level of where the renal veins meet the IVC, then there is likely to be retrograde filling, possibly off the contralateral side, and you can see that there. Also, have a look at this. This is the IVC backfilling into the renal vein, which is dilated. And if you follow this through, the beauty is that this will almost take you to the area within the kidney that has a tumour within that. You see that? So the renal tumour has a lip which extends into the renal vein, which then becomes expanded and then features into the IVC. Are you able to hear me?
Yeah, I can hear you very well. Yeah.
Okay, so right, so that's the feature that we can see there on the CT. So that's axial coronal. Now this is a T2 weighted MRI sequence, and you can see that there is a filling defect which is seen within the IVC. Now this extends to the level of where the left renal vein is, but now you can see that the artifactual filling defect that we were seeing at the level of the left renal vein is no longer seen. So that may well have been admixture artifact in the context of tumour involvement of the renal vein. And as you come back in, you can see the tumour just here. This is the same patient coronal image on the MR sequence. And again, that shows that nice streaky artifact with a broad funneled mass effect within the renal vein and the renal vein dilatation, which then, if you just follow through, it's here, will take you to the mass that you can see just there within the kidney. Do you see that? So this is a very nice long case which will show you the characteristics of a renal mass both on CT and MR. This is a post-contrast enhanced sequence, and it shows enhancement of the kidney as well. Now we're going to go on to a next case. This is another long case that could come up in the exam. So we notice a left kidney. We notice the absence of the right kidney. So whenever you see a CT image where there's no right kidney, you've got to question whether they've had a nephrectomy. But in this context, you suddenly see this lobulated low attenuation change adjacent to and contiguous with the left kidney. And that appearance there is largely cystic. You see a high attenuation area posteriorly, which could be a stone. And then that's contiguous with this tubular structure which crosses the midline and comes further south. So what's going through your mind at the moment?
Cross-fused ectopia.
Yeah, so cross-fused renal ectopia with a normal appearance to the left kidney, i.e. the contralateral kidney is normal. You've got this possibly burnt out cross-fused right kidney, which is fused with the left kidney. You see this hydroureteral nephrosis, and the ureter comes down and is very dilated and then enters this structure here. So what do you see inside the bladder?
Maybe it's a large urethrocoel, I think.
Yes, very good. So you've got a large urethrocoel, which is causing a filling defect and back pressure and obstruction to the right kidney, and equally can cause, for the record, an obstruction to an upper pole or lower pole moiety. Adjacent to this, you've got this structure, which is a
Urinary caster.
a urinary catheter, and you've got some air within the ventral bladder lumen, and that's obviously due to bladder instrumentation. So a nice case of a large urethral and the consequences of that in terms of causing cross-fused renal topic obstruction, as we've just seen here. Okay, so this is the same patient, and I just want you to have a coronal image of this. In your mind, you can see that collection of cystic change. The important feature here is that it has to be contiguous with the other kidney, which it is, and also the ureter quite often is on the correct side, which it crosses over, and you can see it crosses over onto the right side, and follow the ureter down, and then you can see the urethrocoel in profile on the coronal cuts there. Right, hello.
Hello, yes, I'm with you, Doctor.
Okay, lovely. So now we're going to go through an X-Fiver case. So if you could tell me what your findings are on this, on these images.
Okay, so these are selected images of contrast CT in the nephrographic phase. I can see that the posterior portions of the renal cross-section bilaterally is non-enhancing in a crescentic manner. I can also see that the right kidney is surrounded by a hypo-intense rim on the upper cuts. I wonder if this is a case of trauma.
So imagine there is no history of trauma. How often do you see trauma affecting the kidneys bilaterally in this fashion?
Yeah, maybe unlikely without other injuries in the liver, for example. Okay, so we have bilateral renal pathology. It does not look like a neoplastic lesion to me, so I'm more inclined towards maybe lymphoma, or yeah, maybe lymphoma would be my first differential diagnosis. I would like to check if there are any para-aortic or aortocaval lymph nodes. I cannot see any.
Okay, I'm going to stop you there for a second. So remember what we said, description. It's almost the take-home message in a lot of my teaching is about the ability to describe such that I can make a diagnosis at the end of a telephone. So what you've got is you've got an early contrast enhancement, which as you quite rightly say is a nephrographic first phase cortical enhancement, but you start to see a fissured, so remember the term fissured effect that you can see within the renal cortex on either side. You've also got a mass effect from a perinephric encasing soft tissue effect bilaterally, correct? Which is unusual. But also the other unusual feature here is that the extension of this soft tissue change extends medially and causes the IVC to be slit-like as a result. So you have got bilateral changes, fissured appearance inside the kidney, and the medial and anterior aspect of this kidney looks fine. There's no evidence of any fluid elsewhere. So what would you say, what would you like to, what's your diagnosis here? Give me a single diagnosis.
Lymphoma.
Right, now let's look at the imaging in more detail. What do you think now? What do you see?
Okay. I'm checking any other organ affection or maybe any extension into the psoas muscle. I cannot see any. The spine looks intact.
Yep, so spine is okay. There's no extension into the psoas muscle. What do you make of the changes in the kidney here? Do you think the renal parenchyma is involved?
Yeah, for sure the parenchyma is involved, yeah.
Yeah, so the renal parenchyma is involved in. Now have a look at this. So the impression here is that you've got a hemispherical crescentic appearance here on the right side, and you've got a scalloped. So remember, terminology. It's so important to define your terms. And here you've got a scalloped effect, which is causing slight mass effect within the left kidney, which appears to be marginally pushed anteriorly. So there's that effect. There is an encasement effect from the soft tissue changes that you can see with the fissuring that we've described here. And we've got heterogeneity of renal parenchymal enhancement at the lower part of the left kidney. So what's your diagnosis now?
It's a bit confusing to me, to be honest, but I try to categorize the case under a certain box in my head, and the box is bilateral renal masses in my head, and I only know lymphoma and leukemia, maybe TB, but I cannot find any other features of TB. So that's why I keep saying lymphoma.
Okay, so now same patient. Okay, we decide because the vascularity of the kidneys are compromised, we do bilateral renal angiograms. What do you see here?
So I can see bilateral multiple small aneurysms or pseudoaneurysms.
Okay, so you've got to be very careful. Remember, terminology is important. Are these pseudoaneurysms or are these aneurysms?
Aneurysms.
Aneurysms, correct. So there are small aneurysms, and again, description and location is important. So here, what you can see is that, so I've got, and this is the way you would have, should have described this, is to say there is a catheter-directed selective renal angiogram demonstrated on the right and the left side, and there are segmental end arterial areas of bulbous enlargement of the renal arteries in keeping with multiple aneurysms, microaneurysms of the renal arterial tree. There is a scalloped effect. Do you see this? The renal cortex should be coming out here, shouldn't it? So you've got that in absence. And so the important feature here is the presence of multiple end arterial aneurysms, which are microaneurysms, and an absence of the renal cortex, particularly on the right side and possibly in the lower part of the left side because it's truncated. So what's your diagnosis?
Poor arthritis nodosa. Okay, so it's an lymphoma.
No, it's polyarthritis nodosa. You're absolutely right. So now the next case is a case that I've just brought up just for comparative purposes. And the reason I've done that is because the type of tissue change that you're getting in a perinephric distribution is very different. Yes, the only similarity between the two cases in lymphoma compared to polyarthritis nodosa is that you get this encasement effect of soft tissue of both kidneys, correct?
Yeah.
The difference here is that the encasement effect can cause a scalloping of the kidneys in polyarthritis nodosa, and also because there's a vascular aberrant area of arterial change through the microaneurysms that we're seeing, you start to affect the renal parenchyma. Whereas in lymphoma, the changes are diffuse. They're usually associated with adjacent areas of lymphadenopathy, and there also is reactive fluid accumulation, usually within the abdominal cavity somewhere. It could well be in Morrison's pouch, and that would then mean that the process is more systemic than polyarthritis nodosa. Now, the other thing that I want to ask you is, polyarthritis nodosa, PAN, affects which other arteries?
So it can affect other visceral arteries like the superior mesenteric or splenic.
Yeah, so splenic less so, but other visceral arteries, including SMA, celiac axis, and the IMA. Now, we're going to go to another case. We've got a 55-year-old male with left-side loin pain. Ultrasound shows possible hemorrhagic cyst on the left side. No calculus has been seen. Please describe.
So this is a prone unenhanced CT of the...
Did you say prone?
Yeah.
So which bit is this prone?
Because the table is over the anti-abdominal wall, the CT table.
Okay, good. Well done. Okay.
So, yeah, so I can see that there is a large, well-defined, slightly hyperdense exophytic lesion situated on the left kidney, posterolaterally.
Yep, so you've got a hyperdense lesion on a non-contrast CT within the posterolateral region of the left interpolar kidney, okay? Immediately on a non-contrast CT, your consultant at the end of a telephone call, remember that's your descriptive gold description that you should be able to aim for, is thinking about a hemorrhagic cyst, right?
Yeah.
This is the same patient. They go on to have an MRI scan. So what do you make of this?
Okay, so on this sequential axial different sequences, I can see that the lesion is not as homogeneous on CT. It has a central necrotic core. It's not necrotic, sorry for the terminology, but yeah, it's on the contrast, central unenhancing center, but the periphery is nodular enhancing. This on the post-contrast images, which is the lower row. On the upper row, I can see there is a T2 image. The lesion is of high T2 signal. There is, and on T1 signal, T1 weighted image, I can see the lesion has a peripheral high signal.
Okay, so what you've got is, so the key here is that you've got, so what have you got? A T2, you've got a T1 sequence, you've got contrast enhancement, and you've got sequential contrast enhanced sequences, which are T1 T1 fat sac post contrast enhanced sequences, and you can see that there is a lesion which demonstrates peripheral lobulated contrast enhancement with no enhancement of the central aspect of this lesion, and therefore the features are typical for what?
So it's RCC cannot be excluded, but classically oncocytoma is described in a similar fashion.
Well, would you say that this is a spoke-like scar tissue centrally?
Yeah, but pathologically it cannot be differentiated on imaging, and this lesion has to be examined histopathologically.
Okay, so the thing about this lesion is it's well circumscribed, correct? It doesn't appear to be infiltrating. It's got very well demarcated margins. That is absolutely crucial. It doesn't have a serrated margin. It does not have a margin that is a poor zonal definition from the rest of the kidney, similar to the zonal definition that you use for bones. So that denotes whatever this lesion is, it is not malignant. Okay, and so pattern recognition is important. We've got areas of central enhancement, not central enhancement, peripheral lobulated enhancement, which then start to become less enhanced later on. And so the features there are typical for a hemorrhagic cyst. And you tend to see this appearance where there is a differential area of cystic change with solid change, but the solid change is typical for hemorrhagic change. The next image shows a contrast-enhanced ultrasound, and this is another example of how you can define your suspicious lesion on a CT or an ultrasound that you're not clear about. You can give contrast, and that can define the benign nature of this lesion, which in this case was proven. So, but this doesn't get shown on the exam, but it's an important piece of information that you should be aware of. Dr. Khan.
We have to go to the next candidate, please. Candidate 4.
Thank you.
Hi.
Hello, welcome. So just before we start to do your Viva cases, we're going to be starting to just go through a few Bosniak classifications or the Bosniak classification, so that, you know, we're all aware of what we're dealing with. Now, I'm referring to Chapman, and this is an outline of the type of Bosniak cyst that one needs to be aware of. And as all of you know, this Bosniak 1 to Bosniak 4, the classification has been updated in 2019. A Bosniak 1 refers to a simple cyst, that's all. A Bosniak type 2 is a cyst which is minimally complicated. Okay, that means that there may well be an internal area of septation within that cyst. Then the confusion and the difficulty comes with the Bosniak 2F, which is here. and the Bosniak type 3 renal cyst. I don't know whether any of you are updated in terms of the Bosniak classification, which has come out in 2019 from Radiology, but that's a paper that is to be referred to. And what is important is that the Bosniak 2 and 2F distinction is usually made by thickening of the internal septations, areas of calcification seen within the 2F cortical margins. And the distinction between a 2F and a 3 is where there may well be areas, or there are areas of internal measurable enhancement. There are areas of septal internal thickening which are greater than 4 millimeters. And there is a heterogeneity of the appearance of the renal cyst such that there may well be an area of nodularity which shows contrast enhancement above and beyond the internal fluid, or there may be enhancement of the wall of the cyst itself, which then categorizes this into Bosniak 3. This makes a huge difference because I've worked with urologists in some of the oncology centres who suggest, and this is the trend towards what is happening in London Cancer, that Bosniak type 3 renal cysts, as defined by an area of measurable enhancement, tend to get biopsied. So there's a big management decision that's made on the basis of this. Bosniak 4 is clearly malignant, where there is a larger emphasis on the degree of solid nodularity which shows enhancement. But these can be classified and referred to by Chapman, and please refer to the Radiology Journal reclassification in 2019, which gives you an overview of the Bosniak classification from last year. Now we're going to go straight on to a Viva question. I want you to tell me if you can see any abnormality, and the right kidney status is one of post-nephrectomy.
Sorry, so I didn't catch the last part, but anyway, the 2 axial CT images in this screen, the right kidney status is post-nephrectomy. On the left, I note that the left kidney is atrophic, and there's a subtle area of increased density in the fat posterior to it. And
okay,
I think that's the main thing I saw initially.
Okay, so you've seen this abnormality, correct? So there is a area of ground glass change posterior to the left kidney. So the question here is it arising from the kidney, or is it a lesion that could be something more sinister arising from the fat? But you can see a cortical breach here. Can you see that? That cortical breach with that extension into this is implying a benign nature to this, and it's arising from the kidney, and therefore that is an angiomyolipoma with a area of vascular internal enhancement. Okay. So fat-containing renal masses, and that's what we've just shown, but other things that could contain fat are renal cell carcinomas and liposarcomas. This is another Viva question. I'm just going to show you this distinction. Essentially, what do you see here?
So there is, these are sequential axial slices of a CT scan. There is a large mass lesion centered on the right side where the kidney is supposed to be mostly replaced. There's possibly a claw sign as well, I think. And sorry, I think the kidney is pushed anteriorly, significantly anteriorly.
Exactly.
And the lesion is fairly well circumscribed with areas of high density and low density. I think looking at these appearances, these would be in keeping with a lesion arising from the adrenal. And
okay, I'll stop you there. It's not arising from the adrenal, but what the important distinction here is there is a large retroperitoneal mass which is displacing the kidney anteriorly. It's not breaching the cortical margins, and therefore and it's got fat density, and it's got central areas of enhancing solid component. Therefore, this is a retroperitoneal liposarcoma. Okay. Now, this is another example, and I'm just going to take over this case if that's okay. This is a fat-containing abnormality, which has this this area of moderate enhancement seen within it, but the fact is that it's breaching the cortical margin just here, so therefore it's contiguous with the kidney, and that's a sign that to look out for. And this is therefore a hemorrhagic transformation of an angiomyolipoma. Now, what do you see here?
So this is a single image axial and coronal.
I can't hear you.
So a single axial slice and a coronal slice of a CT scan. Contrast has been given. Both kidneys demonstrate several low attenuation and slightly increased attenuation cystic or spherical lesions. On the right side, some of them appear more axophytic. I don't see any venous abnormalities or arterial abnormalities, and there's some, I think there's some periaortic lymph nodes as well, possibly.
Okay, so multiple lesions kidney, and what do you think these lesions are?
So I think these are AMLs.
Okay, so multiple AMLs. Are the kidneys enlarged?
They are not enlarged, no. Not
okay, so good. So the key here is, are the kidneys enlarged, yes or no, because you've got multiple lesions. Are the lesions confined to the cortex or the medulla, or are they corticomedullary? They're both, correct? And is there any involvement of the collecting system? No. This was a case of tuberous sclerosis and can typically appear in the exam, and is a favourite for the fellowship exam. And this is a subependymal ependymoma, sorry, and that's typical for tuberous sclerosis, and it could appear in the exam. Okay. Yep. Another Viva case. This patient has got what?
So he's got a renal laceration and trauma with a hematoma around it.
Okay. Yeah. Happy with that?
Yeah.
Sure.
Or I'll just take a quick look at it.
No. Okay. So you've said
there's a low attenuation area lateral to it. So this could be if there's no trauma, I think this is an AML which has bled.
Yeah. So always look for, with this trauma, just look for any ancillary signs in terms of the thoracic cage or adjacent viscera. There is none. There's a large hematoma which is circumnavigating the left kidney. There's a low attenuation. That's your key, okay, and that's causing a local bleed. Now, this is a 42-year-old with intermittent hematuria and sudden hematomasis with pain in the abdomen. What do you see here? Do you see anything here?
So just taking a quick look at the images. These are sequential axial non-contrast slices. GI contrast has been administered. Given that he's got intermittent hematuria and sudden hematomas, I'm looking for possible aneurysms.
Okay, good. So possible aneurysm. So we'll give you a contrast study. There you go. Does that help?
So in the top row, extreme right image, there is a area of abnormal enhancement. I think it's within the bowel, centered anterior to the left renal vein. Looking at the subsequent images, the lower slices, I think there may be an aneurysm or a active bleed into the bowel there.
Okay, so good. So you can see this, which is a high attenuation area within the duodenum, which on the contrast phase is important. I'm just going to marry all of this up together with you as well, so you can see an area of enhancing enlargement of a renal arterial focus within the right kidney. That's a renal artery aneurysm. There's a bleed within the upper duodenum, and there's this structure here as well. Okay, so that's an area of enhancement with an area of peripheral thrombus, possibly. Where do you think that is?
It's gone beyond the L1 level. Could there be a pseudoaneurysm of the?
Okay. Okay, so let's have a look. So we've got a coronal image shown here. Now, tell me where that is, please.
So that's within the small bowel mesentery, I think.
Okay, so where is it coming from? I'll tell you. So let's marry this up. So remember, you've got a small aneurysm of the renal artery. You've got a GI bleed causing hematemesis. So that's active extravasation into the bowel. And this is a pseudoaneurysm of the jejunal branch of the SMA. You can see the SMA here, the continuity of the ileocolic artery, and the first branches coming off on the left-hand side are the jejunal branches, and you've got that. So marrying this all up together, you've got a diagnosis of polyarteritis nodosa. Okay. And this is important because it's an FRCR exam favourite. So we've shown you two cases today of PAN, one with a circumferential renal involvement with the differential involvement of the renal parenchyma, and this one with a GI involvement, pseudoaneurysms, and a renal artery aneurysm that have both had the same underlying diagnosis. So these are two different presentations of the same condition. Right, we're going to go on to this one. This patient has had chronic left-sided loin pain and dysuria.
So these are sequential CT axial slices of a patient with chronic left-sided loin pain and dysuria. In the topogram image on the bottom right, I note that there's calcification, which is taking the contour of the renal pelvis.
Okay.
And that's probably, I mean, I'll just look to the rest first, but there's some little thinning of the left kidney, and there's some lower attenuation areas within the renal, central to the renal cortex as well. And the right kidney appears unremarkable. There's a spike of calcification in the non-contrast image on the top left, and normal enhancement in the bottom left and central.
What's your diagnosis?
Appearances are in keeping with a xanthogramnosis pyelonephritis in this patient.
Good. So key things here, you've got pelvic ileocecal distension and obstructing calculus, you've got global cortical thinning, possible enlargement of the kidney, and you're right to pick up the signs from from the bottom right-hand side there. We've got another example, therefore, of fat-containing renal mass. The other thing here was I was going to show you some fat within the XGPN that you've got here on the left-hand side, and that goes with the findings from the differential in Chapman. I'm going to show you another case. This patient has got renal impairment, EGFR 14, suspected pyelonephritis on ultrasound. What do you see?
Okay, so these are sequential axial images of a CT. I think this is non-contrast. In the bottom two images, there's some calcification in the, possibly in the line of the left ureter.
Okay, I would ignore that.
Okay. So going back to the top two images, the left kidney appears abnormal. So suspected pyelonephrosis. So there's some subtle loss of corticomedullary differentiation with increased attenuation within the pelvic helix system, and I think this is because of gunk, as in because of debris within the pelvic helix system.
Okay, so I'm going to stop you there because we don't know at the moment. So what you've got, just to recap, you've got a left kidney which shows some fullness of the collecting system here. You've also got breach of the cortex here, which extends into the region adjacent to the spleen. There's slight bulbous prominence of the left distal ureter at the level of the bladder. And at the moment, we've got a non-contrast CT. That's all we've got. What else would you like to do?
I'd like to do a CT urogram, please.
Can you do? Are you happy to do a CT urogram?
No, I'm not. So if there's acute renal failure, yeah, I'll be concerned. So we can do an MR
Okay, so we do an MR. So what have we got now? So this is the MR. You can see that the kidney T1 and T2 weighted sequences, and you can see a little bit of fullness of the left kidney. You can see that, right?
Yeah.
So let's go on and do some further imaging. Can we give contrast as well?
Ideally, no, but we can do time of flight, I think, possibly on this.
So,
possible on this now.
so you don't need to give contrast in this context. I mean, the risk of giving contrast is what?
You can get your, I mean, I can't remember the name now, but
NSF. Okay, so no contrast should be given below an EGFR cut of 30, and that enhances the risk of NSF. So what have we got here that I'm showing you here now?
So these axial sequences, which are fat saturated, demonstrate high signal.
Sorry, these are what sequences?
I thought these are fat saturated.
No, these are so for recognition, this is important. These are DWI sequences.
Okay, sorry. Yeah.
Okay, so so if you look from the top to the bottom, progressive higher B values, and what's the residual change that you're seeing on the left kidney now?
There's less signal intensity. I'm not sure about this. Sorry.
Okay, so basically, in essence, that you've got a case where you've got something that looks like fullness of the collecting system. The patient's got a suspected infective etiology to the symptoms, low EGFR, so they're in renal impairment. The scan, the coronal T2 weighted sequences demonstrates fullness. The DWI sequences on the progressive higher B values demonstrates high signal change, which therefore could imply one of two things, either inflammatory or malignant change. But obviously you're not going to get a malignant process which is diffusely affecting the collecting system, and therefore the features are typical for a system that's full of past pyelonephrosis, which has now been confirmed by the restricted diffusion seen on DWI, without the need for contrast because of the risk well, you couldn't give any contrast on the CT because of the EGFR of 14, and the risk of nephrogenic systemic fibrosis in this patient is high. EGFR is 14, so the DWI sequence in this case and many cases of those patients who've got pyelonephritis or pyelonephrosis in this case is very useful and invaluable, and indeed this patient required a nephrostomy and drained pus. So this is a reminder for everyone to feed back continually. This is another case. This is retroperitoneal fibrosis, and I want to ask you why.
So there is retraction of the mid-ureter more centrally.
So retraction is not the term, so there's medial displacement. Okay, so that's the terminology that you should be using, not retraction. So medial displacement, correct? Yeah, that's right. This is the differential from Chapman, which shows that retroperitoneal fibrosis is the second most common cause of medial deviation of ureters. Now, this is another one.
Excuse me. Next candidate, please.
Okay.
Thank you.
Thank you.
Hello.
Candidate 5, are you with us? Yes, I can. Okay, just bear with me.
Hello.
Hello. Can you hear me?
Oh, hello. Can you hear me?
I can hear you. Can you hear me?
Yes, I can now. Yeah. Hi.
Good. Okay, welcome. So, unfortunately, you're straight into a Viva question here. Please have a look at these series of axial CTs and tell me what you see.
So presented with serial axial CTs, as you've kindly told me. In the nephrogenic phase, there is soft tissue thickening in the para-aortic region that seems to be emanating from the bifurcation upwards to just below the renal hilar. There is medial deviation of the ureters associated with this. Features are consistent with or suggestive of retroperitoneal fibrosis.
Okay, good. So the key here is that there's medial displacement of the ureters. There is a soft tissue encasement effect around the retroperitoneum, particularly involving the aorta. And the thing that you haven't, or perhaps you have mentioned, I don't know.
Left pelvic heliceal dilatation.
Yes, good. So there's left pelvic heliceal dilatation, as you can see. And as soon as, and this is an exam mode question, as soon as you talk about pelvic heliceal distension of any description, do talk about the cortex as a result of that. Is there any cortical thinning with that, or is there cortical renal preservation with that? Because that's important. Now, you talk about RPF. So can you just tell me, is RPF associated with any other autoimmune conditions?
So it's commonly associated with an IG4 autoimmune process.
Yep, so exactly right. So the RPF is associated, or is part of a spectrum of conditions that are IgG4 related, and the IgG4 related disease process is also associated with various autoimmune conditions, which include pancreatitis, cholangitis, thyroiditis, and pseudo tumours of the orbit. Okay, so good. Another Viper question. What have we got here, please?
So I've got a retrograde urethrogram. So I've got a study progressing.
Say that again. Retrograde.
Retrograde uretroscopy. They placed
retrograde pyelogram or uretroscopy. Uretroscopy is the procedure, so be careful. Retrograde pyelogram is what you have. So carry on.
So I've got a retrograde pyelogram working from showing a pre-contrast progressively through to delineating the whole right ureter along its length. There is a dilated right pelvic heliceal system with clubbed calyces to coming down to a narrowed and small caliber, almost pinpoint caliber PUJ. There is some distal opacification, but I think, and some kind of, I think this is all peristalsis along the tube distally. So my concern is this represents a bright PUJ obstruction.
Correct. So good. So you've absolutely right. So there's a retrograde catheter inside the ureter. There is evidence of a stricturing of the right proximal ureter at the level just beyond the pelvic-ureteric interface. I'd just be careful about PUJ. We all know what it means, but sometimes the examiners like you to be just spell it out for them. So pelvic-ureteric interface is there. Just beyond that, you've got narrowing of the proximal ureter, as you correctly said. Now, another case. What do you see?
So I've got a female presenting painless hematuria. I've got pre-contrast axial CT in the first image on the left, proceeding to corticomedullary phase, and then some delayed contrast. So this is a dual bolus study potentially, because there is. Yes. Sorry.
Sorry, Karen.
No, I suspect this may be a dual bolus cut study because I've got synchronous corticomedullary differentiation as well as contrast within the upper ureters on the slices that I've got available to me. Okay. So on the pre-contrast study, there is no increased density to indicate stones or renal calcification.
Concentrate on the right kidney, would you?
On the right kidney, there is the impression of a pelvic calyceal mass with a filling defect, most notably in the penultimate image on the inferior kind of line of images. There is a hypodensity with contrast around it, so I'm suspicious that there may be a urothelial lesion in the right renal pelvis.
Good. So exactly right. So just as you say, the thing I would have described is on the pre-contrast study, there is filling, or there is a fullness of the right collecting system, the renal pelvis. This doesn't appear to be extending into the calyces, and true to effect, you've got a sequentially enhancing soft tissue mass, which is causing effacement, a mass effect seen within the renal pelvis, and that effacement and that separation of the calyces from the renal pelvis is demonstrated on this en-face view here. Okay, and the features are typical for TCC. Well done. So urothelial tumours are an important neoplastic cause for renal sinus masses, and if you go to another differential from Chapman, the filling defects in the renal collecting system, or ureters, often referred to TCC, which can arise from the smooth and can arise from the wall with smooth margins, as we had in this case. So talk to me about this film, please.
So I've got a IVU 20-minute delayed. In my normal practice, I'd look at the control. I have got a normal appearances of the right pelvic calyceal system and ureter, I think, and filling of the bladder. The left is in a drooping lily sign. I think there's a drooping lily sign, and non-opacification of the upper moiety of the kidney, or upper pole of the kidney.
Good. So exactly right. So we've got a 20-minute single image of a urogram of an IVU series. The plain film, which you correctly said is the standard practice to look for, was normal. So we've got a drooping lily sign with a possible upper pole obstructed moiety, but we don't know. This could be caused by various things. This is a reference to a page in the Chapman text, and that shows in this case that indeed there was a duplex system with an obstructed upper pole moiety, which was causing a mass effect. But that in itself is not the only cause. There could be a cyst or a tumour, fetal lobulation, dromedary humps, many causes of a drooping lily sign, which is outlined here. How has the image on the right-hand side of the screen been acquired here?
This is a micturating cystourethrogram in a child. So they've catheterized the patient with usually a feeding tube, instilled contrast, and then waited for reflux. And there is, yeah.
And what sort of French size catheter do we use for that? Do you know?
Typically it's feeding tube, so I think it's probably 8. It's less than, is it an 8 French?
No, 5 French is pretty standard for this. Well done, that's exactly right, so well recognised. Now, we've got this 66-year-old with a right upper pole possible hemorrhagic cyst on ultrasound. See what you can think.
So I've got a pre-contrast axial CT on the left and a post-contrast in portal venous kind of nephrogenic phase on the right-hand side of the screen. The cyst on pre-contrast is not of fluid density, it's just soft tissue density, and on post-contrast is slightly hypodense to the enhancing parenchyma. So I think that this is probably, it represents a hyperdense cyst essentially.
Okay, so it's a hyperdense cyst, as you quite rightly said. It's a solid lobulated part exophytic cyst seen within the posterior upper pole of the right kidney. Note on the pre-contrast study, there are areas of geographical attenuation within the liver, almost looks like high attenuation segments here, but this is because of a fatty liver, and that causes that appearance. So don't be confused by that. Slightly high attenuation on the pre-contrast and intermediate attenuation on the post-contrast study. So talk to me about the MRI sequence that we have here, please.
So the top left image is an out phase because of the India ink.
Good.
And I would hope that it's been put next to the in phase because that would be kind. And then I'm looking at dynamic contrast enhanced T1 fat sat images. So the hyperdense cyst is hypo intense on out of phase and in phase, so there's no signal dropout, and it wasn't hyper intense on T1 anyway. And then there is contrast enhancement though within the cell.
What's your diagnosis here?
So I'm concerned that this is a RCC.
Okay, so, oops, sorry. So this was a focal area of, this was a hemorrhagic cyst actually. So, yeah, so we're going to move on. This is a nomenclature for trauma. And the only reason I'm showing you these images from radiographics is to get the terminology right. Lacerations, transections, and remember renal trauma can also involve the main renal artery, and that's a grade 4 laceration or injury to the kidney because it can obviously cause complete loss of blood flow to the kidney. Another feature to look out for is a subcapsular hematoma, which causes a stripping effect, and we can talk about that. I'm not going to show you this. This is a busy slide from the same trauma series. But suffice to know that if you ever have any evidence of a renal injury, and it's a trauma series, and the examiner asks you which sequence you would like, ask for an excretory phase, because that can show you the kind of contrast extravasation that we've seen here, which is significant, because obviously that means that immediate treatment is required, and the urologists need to be involved, or the interventional radiologists need to be involved imminently. These are a series of images from renal injury patients, sort of really marrying up with the classification from radiographics that we've just shown you, with grade 1 lacerations to subcapsular hematoma formation that you can see here, which gives this bizarre crescentic appearance, and this mass effect which compresses upon and causes compromise of renal parenchymal perfusion. Now, this is a plain abdominal radiograph, and what do you see?
So the patient's got a catheter in situ, and there's been contrast that's been instilled, and there is extravasation of contrast into the peritoneal cavity, outlining dilated small bowel loop. So this is consistent with intraperitoneal bladder rupture.
Okay, good. So that's exactly right. And this is the same process, but in a different case, and it's an intraperitoneal rupture. You can see the contrast outlining the peritoneal cavity. So what's this then?
So similar study, so there's catheter in situ, contrast has been enhanced. Contrast has been instilled, sorry. The bladder dome has got an abnormal configuration, and I'm suspicious that there may be an extraperitoneal leak, although I'm not seeing kind of typical. You can get kind of butterfly leak within the perineum, which I can maybe make out. So what you've got here is an example of an extraperitoneal
rupture of the bladder. The importance here is that the rupture is contained here. There's no peritoneal involvement, and you get this sort of striated butterfly appearance laterally. There's a lack of space, remember, around the region of the lower pelvic extraperitoneal bladder region, which confines the contrast coming out towards the lateral and posterolateral aspect of the bladder margins, which is what you're seeing here. This is another example of the same case, so we won't dwell on this, but hopefully if you do get any evidence of a rupture and you're suspicious for it, always look for bony injury, which you can see here, and you've got some contrast that's just opacifying the left lateral bladder wall just there. You can see the bony demarcation. You can see the subcutaneous edematous change from the trauma, and you can see here inside the bladder again, and the bladder catheter. Right, so this is a 34-year-old female with intermittent hematuria and melena.
Okay, so I've got sagittal, sequential sagittal slices of an MRI female pelvis of a woman that's presenting with intermittent hematuria and melena. At the dome of the bladder, there is hypointense deposits or lesion that is causing indentation of the base. This looks to be extra vesicle causing extrinsic pressure, and there is at the further kind of deposits in the pouch of Douglas, or that is causing kind of retraction of the rectum. A unifying diagnosis for these appearances and the presentation would be an endometriotic deposits.
Okay, so good. So key features here, you've got a lobulated soft tissue mass. I suspect this is actually involving the bladder wall and possibly projecting into the bladder lumen. You can see these punctate high signal areas of change on the T2 weighted sequences and the low signal mass. Typical appearances, almost pathognomonic for endometriotic plaques. Further deposition seen here within the sigmoid colon. You can see a tenting effect to the vaginal vault just at the top end here, and that tenting effect means that there is an adhesive band to the sigmoid colon. A further adhesive band is demonstrated within the sigmoid colon just at the level of the bladder dome, and the radiological features are most consistent with multifocal endometriotic plaque deposition. Good. Now, 62-year-old female, left iliac fossa pain, exclude diverticulitis. Anything you see here, concentrate on the left side of the CT.
Mm-hmm.
Hello?
Hi, yeah, no, sorry, I'm concentrating too much, obviously. Let's have the left, there's a vessel emanating from the left kidney that's going
Okay, so
anteriorly, so it's no longer,
what's
like,
this?
it's not taking its normal course. It's soft tissue attenuation
So soft tissue attenuation in the region of what?
of the kidney, of the renal vein.
So left adrenal lesion, correct?
Fine,
Yeah.
okay.
Okay, so same. This is the same patient. This is a non-contrast CT study. Houseville unit is 7. So and this is the portovenous phase where there's some enhancement. What's your diagnosis?
Probably an adrenal, cystic, and then enhancing. Is it and then left-sided pain as well? So is it a bleed?
No. So this is an adrenal adenoma. This is benign. Anything with a Houseville unit of below 10 on the non-contrast study, you can forget about that lesion being pathological, even with mild enhancement. So that's the take-home message there. Now, just to, we're not going to dwell on this too much, but just to show you what you should be looking at for adrenal lesions, there are two things. There's something called the relative percentage washout for adrenal lesions, and there's something called the absolute percentage washout. Now, the sensitivity in terms of picking up a benign from malignant adrenal lesion, i.e. adenomas, is based on the washout or the percentage washout that we're looking for. So if you've got, if you're looking at a study and you're looking at relative percentage washout, adenomas show greater than 40% washout, with a sensitivity which is 96% and a specificity which is 100%. Absolute washout, you're looking for washout of greater than 60%. Now, what do I mean by that? So, if you look at a relative washout, you're looking at 2 sequences, okay, and an absolute washout, you're looking at 3 sequences. And what you're doing is you're looking at the enhanced Hounsfield unit minus the delayed Hounsfield unit, and you put that over a denominator of the enhanced Hounsfield unit and times that by 100. And the absolute is based on 3 sequences, and you do this calculation and you come up with the relative or the absolute percentage washout. The causes of adrenal lesions are multifold, and I refer you to Chapman. And again, these are benign causes as well as functional causes as well as malignant causes. I'm going to show you this as another adrenal lesion. So this is a 72-year-old with known lung cancer who was recalled for a non-contrast adrenal CT. Is this an adenoma?
No, it's a metastasis until proven otherwise.
Okay, so you've got a lesion which currently is, and I would stay clear of that at the moment, actually. I would say that this is indeterminate at the moment, because you've got something that on the non-contrast CT is above the Hounsfield unit of 10, and it's 23 there. Right, so now we've got a series of contrast studies here. We've got the non-contrast on the left. We've got an enhanced attenuation during the venous phase and a delayed attenuation here. We put this together, and what's your percentage absolute washout that you have?
83%.
Okay, so what does that mean?
It's an adenoma.
It's benign.
Greater than 60%, so...
Correct. So anything greater than 60% on an absolute 3-phase imaging sequence like this is a benign adenoma, as pointed out there. Now, where you've only got 2 sequences, and we've got 2 sequences here, we've got a venous phase study at 70 seconds, and we've got a 15-minute delayed attenuation phase. You're relying on 2 measurement dynamics. The percentage relative washout is 59%, and therefore this is a adenoma. Good. Right, so here.
Imran, we have to go to the next candidate. Number 6, please.
Thank you very much.
Thank you. Hello?
Hello? Hello?
Hi, I can hear you. Can you hear me?
Yeah, I can hear you.
Okay, good. So you're straight into your first Viva question. We've got a 56-year-old female, incidental adrenal lesion on the right side. Can you name the sequences? What sequences?
So these are in phase and out phase. Out phase is on the right side of my side, which in Cartifact. I can see a right adrenal lesion, which does not suppress on the outer phase imaging, which means it likely does not contain fat and would need to be characterized further.
Exactly. So completely right. So there's no loss of signal, and therefore this is not characterizable. So what will you do then?
So I would do a CT triple phase adrenal protocol and calculate the absolute washout, as I would, or if the patient is on the MR scanner, then we can do the MR contrast images as well.
Okay. So the important thing here, which is important to be aware of, is, as you say, we're talking about chemical shift artifact, and we're talking about relative signal dropout on the outer phase imaging. So just for those of you who don't know, just as an overview, you have the in-phase imaging, which is a cumulative additive phase. So where you're adding the signal of water with fat, and that gives you an intermediate signal on the in-phase study. Now, the outer phase study gives you the India ink outline of the visceral organs, and also is a subtraction phase where the water subtracts from the fat, and that fat subtraction gives you a signal dropout. And if you get a signal dropout, you've got a fat rich or a lipid rich adenoma, and that therefore is reassuring that you have a signal dropout on the outer phase sequence, and therefore that is a benign lesion. Now, this is a Viva question for you. Patient with known breast cancer, bilateral adrenal nodules on CT. Do you see any metastases?
So I see bilateral adrenal lesions, which drop signal in the outer phase study on both sides, which will be compatible with adenomas and benign lesions.
Okay, good. So bilateral adrenal lesions, the differential of which on Chapman shows that metastases are the most common causes of bilateral adrenal masses, but in this context there were bilateral adrenal adenomas, which are the third most common cause for this. This is a patient who had a post-drug reaction anaphylactic shock.
Okay, so sequential CT axial slices in portal venous phase demonstrating abnormality focused on both adrenal glands, where there is increased signal noted, hyperdense lesions. There is also hyperdense lesions, hypodense lesions, with some peri-adrenal fast stranding around that bilaterally, and some traces of free fluid noted as well. With a history of anaphylactic shock, these would likely represent adrenal hemorrhages from the shock itself, and would need to be followed up serially via an ultrasound or CT to see if they improve.
Good. So two things here, as you say, adrenal enlargement on either side, the low attenuation largely bilaterally, so or hyperdense lesions as you've described. More than this being a lesion, this is an overall adrenal enlargement, so I would avoid that term. There is periadrenal striations that you can see, and these are therefore bilateral adrenal hematomas, and the hemorrhagic element of these changes can be seen on these MR sequences here, both sides. So, adrenal calcification, this is a differential slide from Chapman. Hemorrhage previously have caused this. There are many conditions like Waterhouse-Friderichsen syndrome from childhood to Wolman's disease, and these are things that do come up in the exam, so it'd be worth knowing your differential list of causes for calcification within the adrenal glands. Tell me what you see on this sequence, please.
So I've got an ultrasound spot image of the ultrasound. I'm just trying to figure out where this would be anatomically wise.
So this is a cross-section of the bladder, okay?
So there is abnormal appearances at the left posterolateral bladder, where there is a filling defect and a soft tissue mass along the lateral aspect of the bladder. The rest of the bladder demonstrates anechoic signal with some debris within it. In my normal practice, I would examine the patient just in a different view to see if this is antidependent or attached to the wall itself. The differentials of this would include a malignancy or a blood clot if this moves around. So depending on the clinical history and on my practice of moving the patient and examining in a different view, I'll come to a diagnosis from either a mass lesion or a hematoma.
Right, so does colour flow have any use in this context?
Color flow would help as well. If there's vascularity within it, I would be more inclined towards a soft tissue mass.
Okay,
so this demonstrates droplet vascularity within the soft tissue lesion attached to the posterolateral wall, highly suggestive of a bladder tumor, and this would need for the cross-section imaging and cystoscopy for further evaluation.
Good. So the other thing that you failed to mention is that in the context of someone who has got a lesion here, always make sure that you say that if you see something within the bladder and it's a lobulated soft tissue mass, as this is, you put colour Doppler flow on to make sure, as you quite rightly say, it's not a hematoma, and that it's not a hematoma, B, that it's not mobile, but given the contrast or the colour Doppler flow within it, you need to make sure the upper tracts are okay. And as you can see, there's hydronephrosis. So upper tract imaging is important, even on ultrasound. So filling defects within the bladder arising from the wall almost always are going to be a malignancy of some description. Okay, filling defects or masses in the bladder can be due to prostatic or median lobe projection. It could be due to other things like an enlarged uterus, fibroids impacting upon the bladder. So always be aware of an extravesical cause. What do you see here?
Okay, so these are MR images of the pelvis, axial T2, axial T1, sagittal T2. Just gonna have a, and then I see at the bottom row some fat suppressed sequences as well. So just having a proper look at that region.
Concentrate on the front of the abdomen, please.
Sorry, which way? Sorry, did you say?
Concentrate at the anterior abdomen.
Okay, so there is abnormality focused at the anterior aspect of the bladder, where there is a connecting it's actually there is a small cystic region which is connected to the anterior aspect of the bladder, which demonstrates T2 hyperintensity in keeping with fluid. I would suspect this to represent a urachal anomaly, something like a urethral, I can't remember which, there's like 4 categories. It could be a diverticulum, it could be a cyst, but it connects to the bladder, so it's a urachal cyst or something.
Good. Exactly right. So this is a urachal cyst. So the categories, as you know, embryologically, there is a, depending on a normal urachal remnant is this fibrous band which connects to the umbilical region, and that's normal. So if you do see a fibrous band, sometimes it can be a bit prominent. As long as it's not showing any enhancement, then it's benign. Sometimes you can get a continuity of the bladder along the track of the normal path of the urachus, and that's called a vesico-urachal diverticulum. In this context, we had a cyst, as was shown, but you can also have a variant where a sinus can be discharging into the umbilical region, and that's an umbilical urachal sinus. Or you can have a complete patent channel to the umbilicus from the bladder, which is releasing urine. So urachal lesions can be referred to in Chapman as shown there. Now, this is a semi-urethrogram, and I'm just showing you the outside, the outline of the anatomy. You've got bulbous urethra, you've got the membranous urethra here, followed by the prostatic and then the bladder. Okay, so what you want to make sure of is that you've got a full handle of a urethrogram, because these are things that do appear in the exam. So please tell me about this image here.
So I've got a snapshot appearance of a ascending urethrogram. Just having a look at the extent, so I can see the filling of the urethra up till the level of the bladder. However, there's multiple tracks with outpouchings noted through the anterior urethra, likely involving the penile and the membranous urethra. There is mild narrowing of the prostatic urethra, which is probably within normal limits, and then a opacification of the bladder. Just thinking of what could be the causes for these outpouchings. They're quite well defined, and they are.
Are you concerned?
I mean, I don't see any extravasation. I don't see any obstruction up to the bladder level. So it looks like it's probably something chronic. And
and what do you see here? Do you see a filling defect here within these?
Yeah, there are filling defects within. So could there be diverticulum with stones within them? I'll probably compare with any control studies that must be taken before the start of the procedure too.
Exactly. So, so prior to any ureterogram, make sure that you've got a plain film as a baseline, and that baseline would have shown you stones, which would have given you the diagnosis. This is a lobulated appearance to the urethra, which has urethral diverticuli, which are filled with stones, as you quite rightly said. Urethral strictures often come up in the exam in the form of traumas. That is the most common cause, and there are various causes as referred to in Chapman. This is a bit of a nasty incident where a history of gunshot wound.
So with the history of gunshot wound, I think there's multifocal calcific densities throughout noted within the penile region, which might be in keeping with that given history. However, there is complete occlusion of the urethra at the anterior posterior sections, where I'd see a complete occlusion at that site.
So when you say occlusion, what do you mean?
It's strange because I can see there's a catheter actually within the bladder itself as well. So I'm just trying to see how is the other part getting opacified. So I think there's definitely probably be an injury, but I don't see any contrast extravasation, which is slightly strange. If it was an acute injury, I would have seen extravasation and leak outside.
Good. So well done. So the two things are, how are you opacifying the urethra, the prostatic and the bulbous urethra? You're opacifying it through a suprapubic catheter, correct?
Yeah.
And you've got a penile urethral catheter, which is placed here into the anterior urethra, and that's opacifying this. This is clearly not an acute event, but it's part of an exploration of the transection that's occurred within the urethra at this point. So, yeah. Now, you've got a 77-year-old male who's presented with testicular hard lumps bilaterally.
So these are ultrasound images of the right and left transverse sections demonstrating enlargement of both testes bilaterally. There is some soft tissue thickening and hypoechoic halo, some areas of calcification as well. And the bilateral lumps in testes in adult patient differentials will include of lymphoma and metastases. So a further history and cross-section imaging of the chest, abdomen, pelvis would be required.
Okay, so you've got this.
So CT images, axial and coronal sections demonstrating multifocal enlarged lymph nodes, predominantly in the retroperitoneal region and the para-aortic region, which are enlarged by size criteria. Having a look at the kidneys itself, there are soft tissue lesions within the right pelvic-calyceal system.
Good. So that's what I wanted you to pick up. So widespread lymphadenopathy, para-aortic, mesenteric, tumoral lymphomatous infiltration of the right kidney, as you quite rightly said, partly at the left side as well. Scalloping of the vertebral body here on the left side, and the features are those of lymphoma. So the commonest cause of bilateral testicular masses in a patient above the age of 60 is lymphoma. Okay, that's what we've just shown you. Right, ultrasound of intratesticular abnormalities could show a whole variety of things apart from malignancy, and you need to be familiar with hematoma and sarcoidosis. 19-year-old, painful swollen left testes. Is this infection?
No, this is torsion and infarction, as I don't see any vascularity in the left, which is grossly swollen and circular compared to the left side, with some edema around it and some scrotal wall thickening as well.
Okay, good. So the important thing here is that look for the absence of just the vascularity to the testes. Look for the edematous secondary thickening of the tunic albuginea, box fascia. You look for edematous change of the epididymis. You look for a reactive secondary hydrocele that is often present, and you also get subcutaneous thickening as well demonstrated in relation to this, because it's a reactive change, because the pedicle supplying the testicle has been twisted, and that creates an edematous change to the rest of the surrounding structures which are scrotal but extra testicular. So you find an absence of colour flow here, but usually an increased flow around the testicle. So that's that. What do you see here?
I've never seen this study before. So it's MRI of the testes, and I'm looking at 3 views. There is a lesion noted in the inferior aspect of the left testes, which is indenting on the testes itself, not arising from the testicular tissue. And on the contrast enhancement, it demonstrates increased enhancement. So
it shows what signal on T2?
So on T2, this is hypo-intense.
Hypo-intense on T2. And what's so it's intermediate on the T1 fat sat with enhancement. And that enhancement is, or the signal on T2 is low relative to the testicle, correct?
Yeah.
So what's your diagnosis?
So I'm thinking, could it be some sort of a granulomatous granuloma or something of that? I'm not sure actually.
Okay. So what you need to look for is you need to look at the outline of the lesion, which is smooth. It's well demarcated, but it is solid. It doesn't show any peri-lesional fibrous striations to suggest a granulomatous reaction, and it's a solid lesion, and therefore the features are typical for an adenomatoid tumour in this vicinity. Okay, so ultrasound is a useful tool for extra-testicular abnormalities, and anything that appears as a solid lesion, particularly in and around the vicinity of the epididymis, it doesn't have to be contiguous. You have to look at the possibility of this being an adenomatoid tumour, particularly with the characteristics we've just described. Now, we've got a 19-year-old male with an absent left testes.
Okay, so these are ultrasound images demonstrating a normal right testes with homogeneous echogenicity. However, going on to the left side, I don't see a testicular tissue. I suspect in 19-year-old with absent testes, could this be a retracted or a testes which is high riding? I would usually go up and scan up to the groin region.
Okay, and if you've done that, you still can't find it, what do you do?
I would get some history from the clinicians to see if there has been a previous orchidectomy for the left side.
No orchidectomy now.
I'm not sure then.
What further imaging would you do?
For testes, particularly a 19-year-old, maybe an MRI.
So just tell me what you see here.
Okay, so these are MR sequences, and I'm just having a look at the testicular region, and I see that one isolated testes demonstrating normal T2 signal. I'm going to try to look for the other testes, and I see another abnormality in the pelvis, just abutting the bladder anteriorly.
Good.
So there is I think, and that's similar to the intensity of the testes. So it's an intra-abdominal, interpelvic testes.
Absolutely. So what you need to look for, remember, when you're doing an MR sequence, compare yourself to the testicle on the contralateral side, if that happens to be outside, and if it isn't, and you're unfortunate enough to have testicles, both of which are within the peritoneal cavity, then just have a look at the signal characteristics. But high signal on T2, so it's intermediate to high signal on T2, low signal on T1. This has a slightly elliptical appearance given its passage through the inguinal scrotal canal, and it has a surrounding area of fat distribution, so it's not contiguous with any visceral structure here, and the features are typical for an intra-abdominal testicle, and the key here is that obviously there's a malignant potential, and that is what we need to highlight to the urologist. So this is